Good morning, everyone, and welcome to Mediccom Healthcare Society. This is session 5, where we will be discussing heart diseases. Now, let me go through the timetable. So right now, we're going through introductions and welcomes. After that, we'll have Aman Abbas, who will introduce himself, and he'll be talking about universities and other things that will be relevant to you. Then we'll have Group 1 Aortic Stenosis at 11:30. At 11:50, we'll have Group 2 Rheumatic Heart Disease, and then we'll have a lunch break at 12:10. At 1:10, we'll have Group 3 Cardiomyopathy, and at 1:30, we'll have an open ethical discussion to make sure that we can interact with the society and see how you guys think. At 1:50, we'll have another break, and at 2:20, we'll have Brugada syndrome. 2:40, we'll have septal defects, and then at 3 o'clock, our session will end. So now let me introduce the society for those of you who have never been here before. We are Mediccom Healthcare Society. We are a non-profit organization which are responsible for organizing PBL presentations for people to get used to research in healthcare, which we think is quite important. But we also have charity fundraisers for each event. This event will be raising money for the British Heart Foundation, as our event is called Heart Diseases, and we'll make sure that everyone can donate money in the link in the chat. So my name is Aryan Chowdhury, and I have founded the society with Naita Basanuru, who is sadly not here. Let me introduce the whole committee. So first we'll start with Trudy.
Yeah, hi, I'm Trudy. I'm in year 13 and I'm part of the committee, and I hope to study cardiology in the future.
Hello, my name is Arjun Elgar. I'm in year 13 and I study at St. John's College, and I hope to study pathology in the future.
Hi everyone, I'm Ayat. I'm in year 13 in Howells. I don't know what I want to go into yet.
Hi everyone, I'm Darshan. I go to Cardiff Sixth College and I hope to study cardiology in the future as well.
So this is our committee. There are more members, however, they couldn't be here because of additional circumstances. I'd like to highlight your attention to our YouTube channel, where we have different events. Obviously, this is our 5th event, and we've had previous events in the past where our first event was digestion, which we had a series of topics available for. The recording is still available there. Group 2, session 2 was COVID-19 debates, where we had intense debates between groups about certain topics, which was very fun. Group 3 was session 3 was autoimmune diseases, where we looked at certain diseases and raised quite a lot of money for AIMS charity, which was great for all of us. And event 4 was mental health, where we had quite a lot of psychological illnesses and certain things that psychiatrists would have to look for in medicine. And now we're going on to heart diseases. So I'd like to draw attention to our website, which I'll share my screen now and talk a little bit about, and hopefully give you some information that would be useful when planning your next Mediccom event and seeing how we can go from there. So okay, so this is our website. This website explains what Mediccom is, what our aims are, and how Mediccom can help you in terms of your skills and how it can flourish your personal statement and even your interview skills in the future. Since Mediccom is not hosted by a certain school and it's completely independent, you have the liberty to do whatever you like in terms of your research, and you as a society can give us ideas and help us expand as much as possible. So here's what each Mediccom applicant can do as the standard. However, as I said before, we've introduced certain things like debates, or even today we'll have an ethical discussion, which I think will help you think on the spot, which is what you do in an MMI interview or even a panel interview. So if I draw attention to our Instagram, if you could please follow us on Instagram, make sure that our word gets out there to help as many people as possible. And you'll find out about our events through here. And if you have LinkedIn too, you can follow us on LinkedIn. The link will be sent later. But also, if you can check the Google reviews, so if you type in Mediccom Society into Google, you can probably find up here Mediccom Healthcare Society, where you can fill in a review for us or get in touch with us and see if you can even come and host on the platform if you want to as a guest speaker, as we've done in the past for certain organizations such as Health for Curriculum, which was last session. So hopefully now you understand what Mediccom does, and I'd like to pass it on to Aman to introduce himself and talk about why he's here today. So thank you.
Thank you very much. Can I just check my mic's all good? You can hear and see me properly?
Yep, great.
Perfect. Cool. So, hi. Yeah, like I said, my name's Aman. I'm a third year medical student. I study at Barts, which is part of Queen Mary in London. And slightly different from the sort of heart topic of today, but I'm just basically doing a general talk on choosing universities, just because I think now is the sort of final run up, especially for those of you in year 13, but also in year 12, it's a good chance, and also early, it's a good chance to sort of lay out what you're going to be doing over the next year or the year or two for applications to medicine. So without further ado, basically, I'm going to be taking questions. So there's that link. I'll also send it to both the YouTube chat and the Google Meet. So if you want to ask any questions, let me know on that. And I think that's it. Perfect. So choosing universities. The main thing that I want to sort of you guys to take away from this, as somebody who's sort of gone through the uni selection process, especially at Cardiff Sixth Form, for those of you in Cardiff, it's very sort of rank based, it's very competitive, and it makes it out to be this big, like, sort of scary process. Is that when you're choosing your medical school, the first thing you shouldn't really be looking at rank as the first thing, and I have this in a slide later. Look at everything else and start like from a broad view, because even more so than with other degrees, medicine is 5 or 6 years, or even more, depending on sort of the path that you take. If you take years out, if you do intercalated degrees of more than 1 year, if you have to resit any years, and all of these things are like really common, especially resetting years or taking years out, because medicine is such a high pressure course that you will spend a decent proportion of your life, or at least right now, to me, it's a decent proportion of my life. When I've graduated and when I become a doctor, obviously it becomes smaller and smaller every year. But you're going to be spending a lot of time in this city, in this university, surrounded by the friends you make here. And you need to make sure that this is a place that you're willing to grow, because again, that's another thing that university teaches you. It's not just how to be a doctor, but how to be a sort of better person and a functioning member of society. And yeah, so you don't want to just go there because they are ranked number 1, or because that's where sort of family members went and you want to do the same experience as them. You need to be able to sort of give yourself the best chance at finishing this degree, enjoying it, and becoming a better person by the end of it. So on that note, sort of starting out at the most macro location. So where do you study? I needed to study in London, and that influenced all of my choices from sort of this step on. I only applied, apart from Cardiff, I applied to all London unis. And sort of, yeah. So decide where you want to study first. And that is things from sort of, is it just a city? Is it a campus uni? All the way down to sort of, how do you get around in the city? So London, when I first applied, I was like, oh, I can just tube everywhere. It's great. And that is, the tube is great, but it's a lot more expensive than I thought. So I cycle everywhere now. And if I had sort of thought about that, I maybe would have bought a bike in first year rather than waiting until now. And I would have saved a lot of money. Alternatively, if you're sort of in a campus uni slightly further away from a city, how are you going to get around that? Do you buy a bike immediately? Do you have buses? Is everything just in walking distance? Think about stuff like that. think about sort of, do you want to have that sort of campus feel, sort of the student community, sorry. So the student community, certain unis are sort of focal points of towns and cities that they're in. And some towns exist only because of the university. And in places like that, you'll have a strong community between students and everything will be student oriented. Whereas in other places, the uni is just part of the city. And that means that there are students there's the students union, there are certain bars, certain clubs that are very student frequented, but it's not so much of a focal point. So just look at that. And all of these things that I'm saying now, you can only really gain an insight into by going to the university during open days. And I think most unis are at least having one in-person open day. And if you're comfortable traveling, I definitely would be going to as many as you can. And also by talking to people at the university. And you can meet them obviously through going open days, or if you have any sort of links to if you have any alumni at that uni from your school, ask your sort of careers department, ask your head of year if they know anybody who's at that uni, and sort of even more just sort of random than that, find a society that you want to join, or in cases sort of cultural societies, for example like ISOC or Indian Society in my case. If I messaged either of those societies, I know that there are people on those committees that would take the time out to call me and explain what the uni is all about. Like all these questions that I've sort of thrown up just randomly on this slide, they would be able to help answer. So you have a lot of sort of ways of getting answers to everything here. It's just figuring out what's easiest for you. And obviously, if you know somebody there, that's the easiest. Just drop them a message. And most people are just nice if you ask them nicely, and they'll just spend some time to help you. More things to consider, sort of costs of living. I know student finance Wales is a bit better, but not everybody qualifies for that. Not everyone wants that. Think about rent, think about food. And it is a lot. And there are checklists on a lot of websites. So you don't have to sort of panic now. Just make sure that you do consider everything, because you are going to be living there for 5 years minimum. And if you get there and realize, oh, I can't actually afford to live here, that's the worst feeling. And on the other end of the spectrum, that you can get there and realize, oh, I'm really annoyed because I have to take a half-an-hour commute every day to the medical school when I'm on the main uni campus. So like you have annoyances to things that actually like stop you doing medicine, and anywhere on that spectrum are things that you should consider before doing a degree. Other things, yeah, food, like are there nice groceries, like just have a general idea of how it would feel to live. And that's another thing. If you go to an open day, you can get a better idea of that, because you'll be walking around the places that you'll be living and working. So you can sort of see, oh, there are a lot of shops here, or oh, I know that I'll have to like do a bit of a commute to go to a supermarket that's not sort of like a Tesco Metro, stuff like that. Once you've taken a sort of look at what you want in general in terms of the uni, you can look at the uni as a whole and sort of start ranking unis like that. And this isn't sort of the medical school, this is the university. So think about sort of societies, size of the uni, facilities, sports, sort of sports in the sense of like, if you like having a gym nearby that you can go to just to relax, or if you want to do a specific sport, if you want to do a specific society, how well maintained is the place? Because I was going to put how new are the buildings, but that's a bad sort of metric to use. It's not about how new the university is. A lot of universities are really old, and a lot of the buildings in universities are really old. It's just, are they being well maintained? Are they being like renovated? Are they fit for purpose? Because some buildings that I've been to when traveling around they just seem like old schools, whereas some of them are old schools, but they've got all the sort of things that you need in there. They've got all the interactive they have whiteboards, projectors. They've got a review system. Every classroom has a camera and a mic, so the lecturer can record everything. I know some unis just don't have that in every lecture theatre, so some lectures just can't be recorded. So just keep an eye out for that. And again, this is things that you can get by asking students, or later on as well. I have some sites that I found, I think, while I was doing applications, that are just sort of review sites for unis, and people point stuff out, like red flags out there. Other things, sort of student support is a big thing. Like I said before, people will fail. I have failed sort of exams and had to sit like later on, failed essays. Like it happens at some point in 90%, like everybody, honestly. Like you will do something in medical school that isn't how you want it to pan out. And if you have a good sort of student support behind you, it makes a world of a difference. And I didn't really look at that when applying, and I've just lucked out in that my uni has a decent student support service. If it didn't have one, it would have been a lot harder for me to sort of pick myself back up after sort of having to sit late sit or things like that. And it would have just made life just more effort. And medical school is like effort enough without you having to deal with all these problems by yourself. So student support just isn't just sort of mental health and well-being services. It's everything from like residential to sort of dyslexia services to it's a whole umbrella term. And if you go on universities' websites, they'll have a whole page on it. Other things. Okay, I think, yeah, most things on there are self-explanatory, apart from how separate an entity is the medical school. I put this on there because, for example, I go to Barts. Barts is pretty separate from Queen Mary, as in I'm a Queen Mary student, but we've got our own students' union. We've got our own sort of campuses, buildings. Our lecturers like identify themselves as Barts lecturers, not all of them, but the ones who just tutor sort of med, dentistry, neuro are Barts lecturers. And because of that, I get a sort of small community feel when going around the campus and sort of Whitechapel and the other one. And I get sort of the benefits of a small uni while also having the benefits of the big uni of Queen Mary. And in a similar way, sort of BSMS, Brighton Sussex, that's a partnership between two universities. The medical school is slightly different. Some universities, the medical school is just on the main campus and it's just another building. And if that's what you want, that's perfectly fine, and apply to unis that are like that, because it gives you more of a general uni experience. You meet a lot more people. The medical school being separate from the main uni is I know very few non-healthcare like students, because the people I see daily are medical students, dental students, neuroscience, global health. I don't really see any maths, law, sort of any of the sort of non-STEM subjects at all. So sort of that's just something that I've learned to deal with. But if you want to have that social aspect of seeing everybody and broadening who you're friends with, definitely go to a uni that's more central. Other things, well, I've put societies and sports clubs up there. Obviously, you can start your own society for whatever you want, as long as you find enough people. But especially for things like cultural societies and sports society or sports clubs, look at places that have things that you're really passionate about, because what it means is you don't have to set that up. Especially cultural societies, it's very nice to have a society for something that you're like, so either way you're from, or like your culture, your parents' culture. Like I'm Malayali. There's no Malu society at Queen Mary, or at Barts at least. I don't think there was one at Queen Mary either. And that doesn't really bother me, but it would be really nice if there was one. And I'd gone to a uni, because I know like Warwick has one, I think Cardiff has one. And it's something that would be nice for me to go to an event every now and then. And if that's something that you actually really care about, or like ISOC or Hindu SOC, or again, I'm very biased in the examples I'm giving because they're the ones that I've seen most. But things like that, take a look at that, because the more established cultural societies are, the better and the more you can get out of them. And a lot of societies like that, like ISOC, our Afro-Caribbean Society, they have, what are they called? Mentorship schemes. And the more established cultural societies, mentorship schemes are really useful. So again, this isn't a key thing to look out for, but if you have two universities that you're like, oh, I don't know which one I want to go to, or like which one I want to put as my insurance and first choice, take a look at stuff like this, because it will sort of have a domino effect later on in your medical school career, like in terms of help that you get. Once you've looked at the university as a whole, I've sort of it keeps blending into one choice, but you've looked at the whole university, then you start looking at medicine, and you start looking at the course itself and course structure, integrated, traditional. I think everything apart from Oxford and Cambridge now are integrated, so it's not really that big a decision. But things like PBL, CBL, I think EBL is one. They do have small differences, whether you're given a case or whether you're just given a question, and how much control do you have over the course? What are your holidays like? That's a big one. Actually, both of those. So control, like I have student selected components, especially early on, which means that I can sort of control at least 4 or 5 weeks of my year in year 1 and year 2, which at the time I was like, oh, that's cool. But when actually doing it, it meant that I could, if I got bored in the year, in those 2 weeks, I picked something that I really liked, and it really sort of put me back on track to paying attention and like actually putting effort into medicine, because I got to do something clinical. I got to do a subspecialty that I was really interested in. I did anesthesia. So that really sort of reinvigorated me to finish the year and do well in first year. And second I said was, I completely forgot what I said. Sorry. I've genuinely forgotten. Don't worry. Things like that. So in a similar vein to student selected, intercalation opportunities, things like that. You have to move it all in your full years. They may not seem like such big, or moving is a big thing, but intercalation may not seem like such a big thing, especially now that they're not actually given points by FPAS. But if you want to do that, take a look. How easy is it to sort of leave the uni to go do a degree elsewhere? Does the uni that you're applying to have the course that you want to do, or have interesting courses to intercalate in? It is a lot of information I'm giving out, but basically the thing is, just once you've got a shortlist, don't do this for a whole like long list of unis. Once you have your shortlist, really dive into them, look at like reviews, talk to people at the uni, like see how everything is, because you are spending a lot of, I'm coming back to this, you're spending 5 or 6 years of your life there. Key things on this slide that I just want to explain a bit more. Non-medical teaching, do you have any sort of, well, non-medical, like, okay, ethics is a bit of a gray area because that is sort of medical, but things like how GPs function, not the sort of treating patients, but how they function as a sort of business, and how that works, and how the NHS functions, and things that aren't just making you a good physician and a good doctor, but generally improving your understanding of the career that you're going into, or making you a more well-rounded person. And that can even go on to sort of more humanity to topics, such as like just teaching you how to do better essays, better research, like as a knock-on effect of that. And some unis sort of make a big deal out of that. They'll have their own sort of module that's just non-medical stuff, and some unis just integrate it through the year, and some unis just don't do it. Just take a look at it. Placements, this is a big thing. You'll have to sort of ask people about this. And honestly, if you go on sort of students union websites like the MedSoc, or if, for example, in my case, Barts has its own website and medicine is a big part of that, they will have sort of reviews. I've seen at least 2 or 3 unis that do this, of like placements, and you're able to sort of see how hard it is to get there, like how the quality of the accommodation, if they're out firm, if they're in firm, like what the sort of cost is to travel. This is a big issue in London, for example, because you've got 4 or 5 medical schools competing for the same amount of sort of GP surgeries, hospitals. Like, obviously, there are deaneries that each medical school sort of fills, but there are only a finite amount of GP surgeries in each sort of catchment area. And all that means is every year, as they take more and more people in, you have to go a bit further and further for your placements. Or in clinical years, they have more and more people, so they have to sort of keep rotating you around more, or sending you to further outfield hospitals. This is something that you probably wouldn't find online as easily. So, like I said, find a society, find a senior who used to go to your school, ask them how they feel about it. Are there any sort of things you should know, like about commuting to placement, stuff like that? Other things that might influence your choice, of course, how are exams taken? Because if you are the kind of person who, again, you will learn how to study better at uni, and that's a trial and error thing. But if you're the kind of person who's very sort of cram oriented versus sort of you like being on top of your work there, and I'm not going to comment, like, obviously it's best if you're on top of it throughout the year and makes you just a better doctor, but you can't always do that. And if you know that you're going into a uni that has end of year exams being your key exams, maybe that suits you because it's similar to school. Some unis will have 3 in a year, and they're equally weighted, and they're progress tests. When will you start getting getting assessed on clinical skills? When will you start getting assessed on sort of just theory? Stuff like that. you'll be able to find it online. But if you want a more in-depth thing, talk to people at the uni. And then the main things that sort of everybody says, PBL, cadavers, are they, is it dissection or is it cadavers for anatomy teaching? How good is the sort of facilities for all that? Just take a look, basically. Cool. Let me just check if there are any questions. Cool, yeah, just keep the sort of questions coming in, because I probably will finish early, so I have some time to talk about them. Yeah, so I've just rambled on there about sort of how you focus in on a medical degree at a school. That's the sort of main point that I wanted to make. And coming back to this, rank shouldn't be your major differentiator. This is more of a personal thing, because the rank was not a it was a major. It wasn't the first differentiator, but it was a major one for me choosing my universities. And it meant that when I got rejected from certain universities, it really hit me quite hard. I felt like I was like a failure for not being able to get into these unis. In hindsight, unis with high ranks aren't sort of, obviously they're more competitive, but it's not like a direct correlation. Ranking is based off a lot of things, research output, like student satisfaction, and each sort of list will do it in a different way. And it's just not worth it. Look at the more micro things. Look at student satisfaction on its own. Look at where they got that value from. Look at research output. If you want to do academics in the future, if you want to do an academic foundation year, like look at how the research is throughout the curriculum. But don't take rank as a thing on its own, because most, yeah, I'm not going to say all, because there are some new medical schools, but most medical schools in the country have very good reputations, and the new ones have very good teaching, because they have to make up for the fact that they don't have reputations, and they will have newer facilities and things like that. So all medical schools are sort of, they all give you a medical degree, and once you graduate, you're just a doctor. It doesn't matter where you passed out from. Obviously, you will get different opportunities and different teaching at each one, but the end result is the same. And just sort of touching on it, I'm not going to go into a lot of depth, but applications process, you should keep it in mind when choosing what unis you apply for. So I had a stronger UCAT, weaker BMAT. I chose to apply around that. I still always sort of stuck to the sort of two sort of dream unis and two sort of unis that I knew that I definitely fit into their entry requirements, at least for interview, so that I would at least get an interview and know that I'm semi-secure in getting a place. But take a look at like the sort of things that they look at. If they look at sort of your personal statement in depth, if they look at your GCSEs, some places do, some places don't. My GCSEs were decent, but not the best, so I didn't apply to any unis that sort of weighted them a lot, apart from Cardiff, but that's because I know Cardiff only look at the top 9 for my year. You'll be able to find this information if you like sort of look at the uni's website or contact their admissions department. But I did that. I knew that I had at least 9 A stars and everything else didn't matter. So I applied to Cardiff, and also Cardiff gives you some points if you're a local student from Wales. So tactical applications definitely would do them. Don't get hung up on them though. I sort of used them mainly for the sort of 2 unis that I wanted to like at least get interviews for. And then when I looked at my other 2 unis that were sort of dream unis, I just picked based on the previous sort of criteria of where would I be happy over the next 6 years. But again, like I said, I weighted ranking too highly when picking those 2. So hindsight is 2020. But yeah, take a look at all this stuff that I've got on the screen. Look if they want volunteering. St. George's in London has a very good sort of admissions page, because they sort of are very clear on what they want out of you, whereas some unis are very wishy-washy. And a key thing on there is, do you want to stay in the UK? I know most of us do, because we have sort of a link to the NHS. Sort of I want to work in the NHS because I think it's a good thing to do, and it's a nice job. And again, it's not the best work life, etc., but I think it's like it gives you that moral high ground. I don't know, like everybody has their own reasons, and I think it's a good job to have in terms of if you're going to slave away at some job, at least help other people. But if you don't want to stay in the UK, you need to sort of either pretend that you do, or apply to unis that don't care, because you are an investment. Even though you are paying a lot of money in to the unis, at least for home fees, the NHS pays a lot of money per medical student becoming a doctor, and they don't want to take in any people that won't stay in the NHS and won't pay that back over the course of their careers. So definitely sort of consider that when what attitude you have going into your interview. Yeah, and speaking of your attitude, remember why you want to do medicine. It's your application. Like I've said, I've around. I like helping. Like I have that sort of moral reason for wanting to do medicine, and sort of the career is there. And I've got my own reasons for wanting to do medicine, and I picked which ones I thought were sort of appropriate for interview and which ones weren't. But I still know the core reasons why I want to do this degree. And as long as I'm thinking about that through the application process, it meant that I showed sort of this at least passion or interest at least throughout each step, whether that was the personal statement, or whether that was the interview, or even at open days when talking to people. It meant that if you show that sort of want to do medicine, people are more likely to speak to you, and you're not being forced by somebody else or pressured by your school or parents or other relatives or even your own standards for yourself, because you might think that you want to do medicine, but if you can't sort of, if you see yourself in other jobs enjoying it more, or if you're not 100 and it's not even 110, if you're not sure that medicine is at least the career that you'd see yourself, don't waste 6 years of your life or 5 years of your life. You can always do graduate medicine. You can always do other jobs first. I've got a 30-year-old in my class who's worked in finance for 10 years and now is doing medicine. I've got JEPs, so graduate entry medicine or graduate entry program. So they've done a degree and now they're on a 4-year degree or a 4-year degree. I've got people who've done a 3-year degree and now are on the 5-year degree with me. And I know this seems like a really roundabout way now, but you don't want to get locked into a 5-year course for something that you don't want to do, or you don't want to spend 5 years studying medicine and then get a job that's not being a doctor when you could have just done a 3-year degree and got the same job earlier with less debt. So just think about why medicine. And I know everybody says that, but it is, yeah, it's a major life decision, and we are making it very early in our lives. So it's okay to not be 100% sure. Cool. So we've got about 10 minutes. So resources wise, these are some resources that I use for entry requirements. You'll find them everywhere. I'll send them to both chats again. So the top 3 are the ones that I've sort of taken screenshots of. The bottom one is the old version of the Medical Schools Council sort of entry requirements document. And I've only put that in there because it sort of has ratios, application ratios, and they will change obviously, but they give you a decent sort of idea of how many people apply for each role. Yeah, I can't actually paste that in one go. Can you do that, Aaron? Sort of, because it's too many characters to the YouTube chat. Yeah, so it gives you an idea of how many people are applying, at least in 2018. Obviously, that will change. And in the last 2 years, we've seen, because of COVID, application ratios have gone crazy. People have been asked to defer. People have been asked to apply to different unis, like with incentives, money incentives, like degree incentives. So just, it's been weird, but at least from talking to my admissions department, because I was working the open day yesterday, it should go back to a normal intake from next year. So I can't promise anything, but take a look at it. Yeah, but so the other 3 things are just sort of comparing medical schools, at least from an academic perspective. But on top of this, definitely talk to as many people as you can, whether that's in person or just messaging society Instagram accounts. Other resources, these are just, I've literally just Googled I think uni reviews. So it's student room, it's things like that. It's just forums essentially for people to discuss where they're applying or review the degree that they're on, the facilities and stuff like that. So yeah, that I don't want to recommend any of these specifically. So you can just sort of Google uni reviews and find which ones work for you. But yes, so I'm going to sort of start looking at the questions. That's the QR code goes to the Google Forms. That's my email. It's going to be on the next slide as well. But if you do want to send me anything, just mention like that you got the email from here, so I have some idea of who you are, but I'm fine answering quick questions. I don't start sort of placements for another week, but after I start placements, I will be quiet. We'll see how busy that is. But yeah, at least for the next sort of week or so, should be free to answer any questions. Cool. I will go through questions now. Okay, so dissection. So somebody's asked, how important is dissection? Is it important? Is it necessary? I think dissection versus prosection versus sort of, I think everything at least has, every medical school would at least have prosection, is a sort of very personal choice. I can visualize, so I can understand and visualize 3D things quite easily. And I figured that out through sort of sixth form and doing like physics and sort of those sort of competitions. But if you haven't figured that out yet, like just try and do some stuff. I don't know how to figure that out, but if you like look at anatomy and try and if you like read an anatomy textbook and see if you can figure out what's happening and visualize something as you go along. If you can do that really easily, it's less important. But if you can't do that so easily, it's more important that you are able to sort of take apart, well, a human. This is a person. This was a person. Is a person. So that you can see where everything is in relation to each other and in 3D space. And in the same sort of prosection does give you that ability, but it's not sort of you taking stuff apart. It's already been taken apart. It'll be already butterflied or it'll already be opened up, and you can just sort of poke around and take a look. So there's sort of 3 different levels of just theoretical anatomy teaching, prosections and dissections. And it's again, it's a very personal thing. My uni does offer it. It's one of those student selected components. And I thought, I don't really need that because I'm doing okay with anatomy. I think it would be very fun, but this one was more fun. So I picked that instead. PBL and bots. Okay. Yeah. So PBLs, this is what I say to most people who ask me about PBLs. I'm a very lazy person in terms of studying. PBLs are great for me because they force me to study. The PBLs are we're given a case, we're given a problem. So it's not a whole case, it's a presentation, and sort of working together as sort of 8 people, figuring out what's wrong, going away, researching that, coming back and presenting it is a way that I learn very well. I learn very well by discussing things, and small group discussions in PBLs facilitate that really well. So I really like them. I prefer it over sitting in a lecture theater. I do miss going to lecture theaters because obviously COVID has sort of stifled that, but PBLs are a very effective way for me to learn. Unis that I applied to. So again, please don't use this as sort of any reflection because I probably would have applied slightly differently. Again, I went to Cardiff sixth form. If you're from Cardiff, you know what that means. It's a very sort of high pressure school. So I applied Oxford Imperial as my sort of, I really want to get into these unis because they are ranked highly unis. And then I applied to Cardiff and Queen Mary, so Barts, as my UCAT unis. And my UCAT was high enough that I knew that I would get interview as long as I didn't really mess up anything else. So that's why, and I only got offers from Cardiff and Barts. So I was really crushed. But in hindsight, I'm in a much better place, both mentally and sort of teaching wise, because Barts has a lot more clinical skills and a lot more patient contact before either of those BMAT unis. So I feel like I've learned a lot more and I've been a lot happier while learning. Strategically, basically, when I applied strategically, I literally listed out everything that I had, sort of all the values, all the UKCAT scores, BMAT scores, etc. All the BMATs after, I think. I've forgotten the timeline, but I listed everything I had at the time. I went through these sort of documents. I found out I put them into basically an Excel sheet, and I just looked at what matched, what didn't. When I was going through sort of my work experience and stuff, I categorized it under sort of teamwork, leadership, sort of all those sort of skills and qualities that they want. And some unis like George's will let you know, oh, we look for these things in work experience. So if I had a lot of things in sort of teamwork and George's looked for that, tactically makes sense to apply that because they would read my personal statement, they would see a lot of teamwork, and they would like that. But it is just a lot of sort of data analysis. Basically, you're just going online, you're trying to find ads, you're trying to find statistic sort of values for applicant ratios, stuff like that. So it's not always the easiest thing to do. It's just I've just realized it's almost past, so I will just skim through the last few questions. Gap year question. It's not bad to do a gap year, especially if you do something productive. If you do nothing in the gap year, it's bad to do it because it's shown that you have no sort of medical drive. But if you take a gap year and sort of spend some time doing some volunteering, especially if you have the whole year, you could probably get a part-time job working with either sort of elderly people, working in a GP, like a back end in the office, working with children, sort of either working in healthcare, working with vulnerable people if you can, shows that you're building these skills, shows that you have a better idea of what medicine is, because it's not really that glamorous. And it means that they probably will, especially if you talk about it in an interview, they probably will take your application a bit more seriously. But if you're not 100% sure on medicine, definitely a gap year is not that bad of a decision. It's a huge thing now, but if it means that you have more resolve when applying for medicine, consider one. Medical students from certain unis, the resource, okay, so finding students to talk to from certain unis, the two main ones are open days and literally just DMing society Instagram accounts, because somebody will be like willing to reply for most sort of major societies because they have enough people on the committee, and there will be somebody like a welfare officer or just even presidents who will just reply and be like, yeah, sure, this person can talk to you or something like that. So I don't want to go over. Okay, so London in general, I like London. I chose because always stuff going on. Obviously, it's still the UK, so stuff does close. Like the stuff isn't open 24/7. There are some shops, but they're a bit further away from where I live. But no, I do enjoy having so many people around me that I don't recognize everybody, and I don't sort of see the same people every day, because I will see people every day in uni, but I didn't really want that sort of when wandering around the streets or like going to the shops and stuff like that. I wanted to sort of to be able to lose myself in the city and take advantage of all the like museums and stuff like that. And going into another question, medicine is very stressful, but you do have free time. It's a lot of stuff. It's especially in first and second year, it's the breadth of content rather than the depth, at least for my uni. And that means that you have to spend a decent amount of time, but you do have free time, and you can have sort of weekends off or evenings off as long as you plan it well. And if you don't plan it well, you can start free time. It just means that before exams, you're going to have to cram a lot to make up for what you've lost. Other questions that I haven't answered, please just drop me a line on my email, and I can sort of give you a brief answer. But it's past, so thank you very much. Yeah.
No, thank you, Aman. That was really helpful. I mean, that was really great. Thank you a lot for coming, and I hope you have a good day. And please, everyone, email him with any questions. I know there's a few that might have been skipped over, but that's all right. But yeah, thank you for coming.
No problem.
We'll move on to PBL presentations now. So first, I'd like to introduce Dr. Mitra, who will be judging. Would you like to introduce yourself?
Aryan, thank you for having me. Great pleasure to be here. Sorry I can't stay to the very, very end, and I see that there's been some slight changes in the program, and only if you guys wish, because I can see from the topics we've kind of missed out coronary disease, which is a very important part of the cardiac disease spectrum. I presume it was probably part of some of these presentations, which has now dropped out at the last minute. But only if you wish, I can share one or a few slides of my own, only if you wish. But I don't wish to delay your program by any means. So thank you for having me.
No worries. We have some time during 1:50 break if you want to maybe stay and give a presentation, or you can start talking at 1:30 during our open ethical discussion. But we can discuss that later if that's fine with you.
That's fine with me.
Okay, sure. Ayat, do you want to introduce the group?
Yeah, thank you. So we're going to start off with group 1, who are Mehek, Rebecca, and Megan, and they're presenting on the topic of aortic stenosis.
If someone in your group could share their screen and start delivering your presentation. Thank you.
We're just trying to share the screen now. Sorry.
So this is Aortic Stenosis by Megan, Becky and Mehek. So aortic stenosis is one of the most common serious valve problems in the UK, affecting at least 400,000 people, and it is most commonly associated with age. So aortic stenosis is the narrowing of the aortic valve opening. It restricts blood flow from the left ventricle to the aorta, and therefore may affect the pressure in the left ventricle, and as a result may go on to affect the pressure in the left atrium. Okay, so what are the causes of aortic stenosis? So aortic stenosis most commonly develops from a buildup of calcium, which is a mineral found in your blood, on the valve leaflets. So the leaflets are triangular shaped flaps of tissue within the heart valves that open and close to control your blood flow. So over time, this causes the leaflets to become stiff, which reduces the ability to fully open and close. So there are other causes as well, such as congenital heart disease called bicuspid aortic valve, as well as birth defects of the heart, rheumatic fever, and past radiation therapy can lead to valve problems. In aortic valve stenosis, the aortic valve between the left heart chamber and the aorta does not open completely. So the area which blood moves out of the heart to the aorta is narrowed. When the aortic valve opened is narrowed, your heart must then work harder to pump enough blood into the aorta and to the rest of your body. So the extra work on the heart can cause the left ventricle to thicken and enlarge, and eventually the strain can cause a weakened heart muscle and can ultimately lead to heart failure and other serious problems. So some of the symptoms of aortic stenosis are chest pain, a rapid fluttering heartbeat, trouble breathing or shortness of breath. You can be dizzy and lightheaded, have difficulty sleeping. However, many people with aortic stenosis don't experience notable symptoms until the amount of restricted blood flow becomes greatly reduced. And then current research is looking at biochemical cardiac markers as an objective to measure of left ventricular decompensation in aortic stenosis, therefore seeing how the heart failure is coming about and how affected it is.
So next we'll be talking about the diagnosis. So there are a variety of radiological techniques that a physician can use to diagnose aortic stenosis, and these are a 2D Doppler echocardiogram with colour flow, CT angiography, which is essentially an imaging test that looks at the arteries that supply blood to the heart, and a transthoracic echocardiogram, which is when sound waves are sent into the chest and these echo off different parts of the heart. And these echoes are sent to a video monitor that records pictures of the heart. So the 2D Doppler echocardiogram with colour flow is a test in which ultrasound is used to take images of the heart. And this has the ability to display a cross-section of the beating heart, which depicts the chambers of the heart along with the major blood vessels and the valves of the heart. And the combination of imaging and the Doppler enables a physician to determine the level of obstruction. So whether it's subvalvular, valvular, or supravalvular. Can I have the next slide, please? So what are the current treatments for aortic stenosis? So there are a couple of procedures that can be performed, and these are a transcatheter aortic valve implantation, an aortic valve replacement, which is when a damaged heart valve is replaced with one from a pig, cow, or human donor, and a balloon valvuloplasty, which involves widening a narrow heart valve by guiding a catheter to a valve and inflating a balloon at the tip of the catheter at the valve. So in a transcatheter aortic valve implantation, a catheter with a valve in the stent at the end of the catheter is introduced through a small cut at the groin or via the left side of the chest. And when the catheter is positioned in the heart is paced using a temporary pacing system, and a small balloon is inflated, and the valve opens up as the balloon expands, after which the balloon is deflated and pacing stops as the valve is held in position by the surrounding stent, and the catheter is then removed and the incision is closed.
So next is the complications. So as Meg said, the treatment for aortic stenosis is a valve replacement, which can either be performed surgically or percutaneously. So if performed surgically, some of the possible complications include infection, excessive bleeding, blood clots, which can lead to strokes, and irregular heartbeats. But if aortic stenosis goes untreated, it can eventually damage the chambers of the heart, causing them to thicken and enlarge from the extra work. This affecting the ability to contract and pump blood, and dangerous arrhythmias and irregular heartbeats such as atrial fibrillation can develop as a result.
So what are the ethical concerns about the treatment of this? So often cow's valves and pig valves are used as a replacement in the heart, and this can cause religious concerns as well as just people not really wanting this in their body. Additionally, some patients, whilst waiting for assessment, may become too sick for surgery, and healthcare professionals may also decline to perform surgery based on perceived appropriateness. So therefore, if they're feeling that there's harmful behavior or something, then they may decline surgery. So what are the innovative ideas to treat this? TAVR is an innovative surgical option for high-risk patients with aortic valve stenosis. It was first approved by the US Food and Drug Administration in 2011. The Mayo Clinic describes TAVR as a minimally invasive procedure to replace the aortic valve in people with aortic valve stenosis. The procedure helps patients recover more quickly because it involves minimally invasive surgery instead of an open heart surgery, and can often be lower cost and often lead to a better outcome. So during TAVR, doctors usually access the heart through a blood vessel in the leg. Alternatively, they may conduct the procedure through a tiny incision in the chest and access the heart through a large artery or through the tip of the bottom left chamber of the heart. A hollow tube is inserted through the access point. The doctor can use advanced imaging techniques to guide the tube through the blood vessel to the heart and into the aortic valve. Once it is precisely positioned, a balloon is expanded to press the replacement valve into place into the aortic valve. So some valves can expand without the use of this balloon. However, when the doctor is certain that the valve is securely in place, the tube is withdrawn from the blood vessel or from the incision in the chest. And to date, more than 100,000 patients have successfully undergone this procedure. Also, as technology advances, robotic aortic valve replacement is something that has been suggested in the future of cardiac surgery, and this may include robots carrying out procedures. And so far, robots have successfully carried out 50 aortic valve replacements, which is pretty incredible. And this is our bibliography.
Thank you for your presentation. I'd like to invite Dr. Mitra back for his comments.
I think, first of all, I've got to say a huge congratulations to this team to present a complex topic in such a lucid, fashion. You guys have covered quite a lot. and you spoke very, very well. I was particularly taken by how clearly one of your team members, I think it was Meg C, spoke. I wanted to ask your team one or two questions. What do you think about, the various kinds of heart valves? Did you come across that in your research? What about mechanical heart valves? You didn't comment on that. Any comments on my question about mechanical heart valves?
Well, Mahek spoke about the ethical concerns regarding the use of, pig and cow valves, because obviously some religions don't agree with using them because they're like sacred animals. So mechanical valves could provide an alternative to that, hence giving like the patient more of a reason as to why they would want to have the valve replacement, therefore potentially saving their life. And also it may reduce the risk of rejection because it's not accepting these cells from an alternative organism into your body. So there might be some benefits in terms of that.
Can valves be made out of metal? That was my question. The mechanical heart valve usually means they're made out of metal. They don't have any of the pig tissue or the cow tissue in it. And if so, do these valves get put in?
I think they definitely could be put in, but however, I guess there is the chance of failing mechanically, or more concerns as it's not from an organism, it's been made by humans, and it could possibly increase the risk of complications. For example, clots in the heart and in the brain, which could then lead to further problems.
Okay, so traditionally, the first kind of heart valve transplant were, valves made of metal, in a ball and a cage. But of course, nowadays the metal valves have got mechanical leaflets which open and shut. The great thing about valves which are made of metal, the mechanical heart valves, is that they're very durable. They last many, many years. They can go on 20, 30, 40 years. The problem is that these heart valves, as you so correctly have pointed out, okay, you've got to have blood thinners to cope with these heart valves, because what you don't want is the blood to form clots on these mechanical heart valves, which then fail to open, and that'll cause sudden death. And that's why people who have mechanical heart valves are people who also take medicines like warfarin, which thin the blood, and they take it long term. Bioprosthetic valves is the ones that you mainly spoke about, the ones which cow from the pericardium, cow pericardium, or the pigs. The advantage is that you don't have to use warfarin. You don't have to use blood thinners to have these valves. The disadvantage is that they are not as robust as the valves made of metal. And these bioprosthetic valves, if you have a good run, will last you maybe 15 years, maybe 20 years. So traditionally, what we try and do is that if the patient is a little bit younger and they got many decades to live, we might say, okay, maybe they should go for a mechanical valve. And if they are somewhat in the elderly range, in their 80s, we would say, okay, maybe we'll go for bioprosthetic valves, because we're not worried about the longevity here. So that's one of the main, differences between the two. I think you raised a question about whether the body will reject this valve, but this valve doesn't actually. These bioprosthetic valves, they don't actually have many active cells inside, because they're made up of pericardium. There's no cells, they are in cartilage. And so the body you don't need anti-rejection medicines and the body accepts them. They're not like when you have organs put in like kidneys and livers, where you have to really suppress the body's immune system to prevent the body from rejecting these organs. These bioprosthetic heart valves don't need any special, anti-rejection drugs to go in. TAVI or TAVR, as the Americans call it. The Americans call it TAVR, transcutaneous aortic valve replacement. We in Europe, we call it TAVI, transcutaneous aortic valve implantation. And these are also their specialist, tissue valves. They come tightly wound around a balloon, and we numb the groin area. We then pass the tube all the way up into the heart with the help of X-rays. We go through the narrowed aortic valve and we stretch it open, and then we deliver the valves, and then either we balloon it or the valve self-expands, to work. The one other thing which I missed is that what would happen if we didn't treat the aortic stenosis? Would people die?
I would say it could lead to death, or it could just lead to them being very ill and then being more liable for other diseases and problems with the heart, with irregular heartbeats, and just putting more stress and pressure on the heart, therefore in later life making you more susceptible to other heart conditions such as heart failure. And
That's a good answer. Now, the main pumping chamber of the heart, the left ventricle, pumps the blood out into a big tube coming out of the heart. And this big tube is the aorta. It's a main artery of the body. It takes blood everywhere. And guarding the entrance of the aorta, there is a valve, the aortic valve. And normally, as the heart squeezes, the valve opens wide, allows the blood to pass through, and then slams shut to prevent the blood from going backwards. There is no point if the heart squeezes and the blood goes that way instead of that way. Yes? So, in aortic stenosis, if the valve, instead of opening wide like this, opens only about that much. And then it gets progressively smaller and smaller. So the heart has to pump ever harder to force the blood out through a small hole rather than a big hole. And when the heart is trying to do that, it is struggling to pump the blood. And as the valve gets narrower and narrower, for a long time, people don't complain of anything. But when it gets to a critical phase, when the aortic stenosis is severe, people start getting very breathless, which is what you described. People start getting pains and heaviness in the chest. And some people start they start to get to faint or have dizzy spells. And that's when we know that the aortic stenosis is bad. We know that from the symptoms and from what the heart scan is saying. So that's when we have to change the valve, because if we don't change the valve, the curve for death is like a logarithmic curve, and you get about 2 years unless you actually go ahead and do something. So yes, untreated aortic stenosis leads to death if it is severe mostly within 2 years of symptoms. Thank you, team. I thought that was excellent and well done.
Darshan, would you like to introduce the next group? And thank you, Dr. Mitra, for these comments. They were really wonderful.
Also, thank you very much. All right, okay, so introducing the next group, we're going to be presenting rheumatic heart disease.
So good morning, everyone. So over the past week, Hira, Luke, and Jade and I have been researching into rheumatic heart disease. So we're going to show you what we found. So what is rheumatic heart disease and how does it arise? The disease is the most common heart disease for individuals under 25, affecting around 39 million people worldwide. It's the onset of the direct result of untreated rheumatic fever, which in turn is a result of untreated strep infection. Joint inflammation and pain are hallmark symptoms of rheumatic fever, often compounded with several other symptoms, which, if left untreated, may result in lifelong disability or even death. The rheumatic fever causes inflammation to the heart valves, and it can take several years after the episode of symptoms to even appear. So inflammation actually arises as a result of the proteins on the strep bacteria being really similar to the proteins on heart muscle. So therefore, the antibodies in our body attack the heart, making rheumatic heart disease an autoimmune disease. The inflammation of the mitral valve also restricts blood flow between the left ventricle and the left atrium. This means that less blood can be carried, which lowers oxygen levels, in turn leading to shortness of breath and fatigue. Furthermore, pressure builds up in the left atrium where the blood would not leave, causes the atrium to enlarge. Damage to the valve can make it unable to close efficiently, which in turn leads to the backflow of blood, reducing the volume of oxygen-rich blood in the body. This only intensifies the pressure which the heart has to pump out. So let's look further into the pathophysiology of rheumatic heart disease. We've already covered mitral valve stenosis, which is the inflammation of the mitral valve, and mitral regurgitation, which is the backflow of blood to faulty valves. So next is rheumatic pericarditis. The pericardium is a protective membrane that surrounds the heart and consists of 2 layers. In between the layers lies a lubricating fluid, which allows the layers to move smoothly against each other. But however, as a result of inflammation, which comes from rheumatic heart disease, there's friction, which can lead to irritation and pain. Lastly, there's arrhythmia, which is when there's a slowing down or interruption of the electrical signals, which causes the heart muscles to contract and the heart to beat. It includes the disease heart block and leads to palpitations and dizziness. Currently, a huge percentage of people with rheumatic heart disease are discovered too late when the damage becomes severe. The best case scenario is to get tested as soon as possible to avoid it progressing. So in order to diagnose rheumatic heart disease, you need to have a sort of a recent history of strep infection or rheumatic fever. There is a wide range of symptoms such as painful joints, fatigue, jerking, heart murmur, chest pain, shortness of breath, and swellings of your stomach, hands, or feet. And you can also have rapid or irregular heartbeat. Before any checkups take place, a history is taken, for example, family history, because some people carry genes that make them more likely to develop the fever. You also need to research the type of strep bacteria, because certain strains are more likely to contribute to rheumatic fever than other strains. Also, environmental factors play a role in heart disease, because a greater risk of rheumatic fever is associated with overcrowding, poor sanitization, and other conditions that result in rapid transmission or exposure to strep bacteria. What is strep infection? So it's a bacterial infection, and the way it can be checked is like by taking a throat culture or a blood test, and specific blood tests can reveal inflammation and infection. Antibodies are created when your body defends itself from an infection, and it's tested with something called the ASO titer test. So yeah.
The following tests may be used to detect the rheumatic heart disease, in addition to a comprehensive health history and physical exam. So just like an echocardiogram can be used, an MRI of the heart, and an ESR. Treatment for the rheumatic heart disease actually varies based on the damage the heart has sustained. So in severe cases, surgery may be needed to replace or repair a damaged valve. Antibiotics can also be prescribed to people who have had the fever to minimize the increase of damage to the heart. These antibiotics are usually prescribed to be taken on a regular basis to further lower the risk of heart disease. And then medication such as warfarin can be prescribed to thin the blood and thus reduce the risk of blood clots. However, there are many issues with the current treatment. The main issue is the fact that the treatment is not an actual cure for the disease and that the damage done on the valves is permanent. This means that the person affected is required to take the medication on a regular basis, but the medication is also an issue. As I mentioned previously, blood thinning tablets may be prescribed to prevent blood clots, but that comes with its own detriments. They increase the risk of bleeding. Now, this may mean that the patient experiences blood in their urine, severe bruising, prolonged nosebleeds, and many other side effects. I'll now move on to talk about the medical ethics for treating the rheumatic heart disease, and specifically the 4 pillars, which are autonomy, beneficence, non-maleficence, and justice. So with regards to autonomy, a doctor will be required to ask the patient questions about the surgery and then inform them of the risks that would come with the surgery, so that the patient themselves can make the decision of whether or not they'll undergo the treatment. Even if they are in a critical condition, they can deny the surgery. And then with regards to non-maleficence and beneficence, a doctor would be required to make the decision whether surgery or medication would be best for the patient. So they would contemplate whether the benefits of a certain treatment would outweigh the risks. For instance, someone who's had many surgeries, they would not be advised to have another surgery, as the mortality of the patient would increase, and thus the doctor would opt to prescribe medication instead. And moving on to justice, rheumatic heart disease mainly affects people in poorer countries, since they are unable to find or have difficulty accessing the antibiotics required to kill the initial strep bacteria. So when the disease is fully developed, the poorer countries are then, again, less likely to obtain screening, treatment, and access to hospitals. So for them to receive justice, they should have accessibility to antibiotics that are needed to combat the strep bacteria. And this may be done through the works of charities or via technological innovations in the future. The map in front of you shows, supports the evidence of poorer countries having more chance of rheumatic heart disease.
With the rapid development of modern technology in medicine and in our daily lives, it seems foolish not to take advantage of the avenues that our technological innovations have opened. Before I go into talking about innovations involving the treatment of rheumatic heart disease itself, I'd first like to discuss preventative measures, as prevention of strep throat infections, which have the potential to develop into damaging or even lethal heart conditions, is the key to ensuring that patients have the best quality of life moving forward. First, we believe that it is reasonable to issue mandatory strep throat swab tests for any family members who have been in close contact with a person recently diagnosed with strep throat, especially children, the elderly, and immunocompromised family members. By testing these family members who may have exchanged things like cutlery or been in contact with droplets harboring Streptococcus bacteria from an infected patient, we minimize the risk of transmission outside of close family and prevent the development of undiagnosed and therefore untreated strep throat. As mobile devices are becoming more and more widespread, our group also believes that integrating reminders for antibiotic courses on official NHS applications could drastically increase the effectiveness of these antibiotic courses. We as humans can often be forgetful, and some may not understand the importance of fully completing antibiotic courses in order to prevent the growth of antibiotic-resistant bacteria, which may cause a second infection. So it's crucial that we ensure that patients take their full courses of antibiotics even after a partial recovery, making it clear to them during consultations and giving them the necessary resources to minimize error by human carelessness or neglect. Moving on to my next slide. On actually treating rheumatic heart disease itself, I'd first like to discuss the current issues we face with valve replacement and surgical procedures involved. As we have already mentioned, patients can currently choose between biological and mechanical valves to replace their existing damaged ones. Mechanical valves are durable and often do not need replacing for as long as 30 years. However, these are susceptible to developing blood clots and as they are detected as foreign bodies by the immune system, and as a result, patients have to take blood-thinning medications like warfarin in order to prevent potentially lethal arterial or vein blockages. As her has already mentioned, blood-thinning medications carry their own risks of internal bleeding and bleeding out due to an inability of the patient's blood to clot properly. Biological valves, on the other hand, are not as susceptible to blood clotting, and therefore blood thinning medications don't need to be taken, but are less durable and must be replaced much more often as a result. As bioprinting has become cheaper and more accessible, it has become more and more competitive as an alternative to both mechanical and biological transplant valves, as they provide the best of both worlds: the resistance to blood clotting of biological valves and the similar strength and durability to mechanical valves. As you may already know, nanotechnology for medical applications is already in the works and is being developed as we speak. Eventually, we may be able to perform valve replacements without the risks of chest infections, arrhythmia, brain damage, and respiratory issues that come with open heart surgery, through the use of highly advanced nanobots that may be able to perform the surgery internally, though this may not be realistically developed for quite some time. However, there is premise for nanotechnology, as research into using nanotech to imitate heart cells is already in the works. Thank you for your time. We hope that our presentation helped all of you understand the symptoms, treatment, and future innovations related to rheumatic heart disease. We would like to open the floor to any questions.
Thank you for that amazing presentation. It was very well made, and I really like the images you put up. Now I'll hand it over to Dr. Mitra, who will say any comments he has in his mind.
Thank you. Team, very well done. Shruti, Hira, Lucan, you came out very clear. Apologies to you, Lucan. I actually, said a few things which you beforehand, which you sort of stole your thunder a bit, your presentation from my comments from the previous presentation, but yours was spot on. Another nice thing about your presentation where you had some pictures so we could understand what was going on. My question to your team would be, does rheumatic heart disease, does it affect the heart valves straight away, or is there a time gap between when you have the rheumatic fever and then the rheumatic heart disease, or is it like is it instant?
So I'll answer that. So obviously it does happen after the fever, and the valve damage may start a little while after the untreated streptococcal infection. So if there was a period of time to be given, I'd say about a month as a maximum point.
During rheumatic fever, there might be some slight inflammation of the valves from the floating immune complexes. But the strange thing is that even after the disease is gone, the rheumatic fever is gone, many years and decades have gone by, the heart valves, some kind of warping process starts inside the heart valve, and they're not manifest until 20, 30 years go by sometimes. Rheumatic fever is a disease of the young, whereas rheumatic heart disease is a disease which presents decades down the line, when the valves, due to that initial insult, they start warping. The most common valve involved is the mitral valve, but the other heart valves can also be involved. So, you mentioned heart rhythm disturbances. Are there any typical ones which result from rheumatic heart disease? Any common typical heart rhythm disturbances that you know of?
Would that be heart block?
You can have heart block, although that is less common. More common is a kind of fast and irregular heartbeat. Can anybody say?
Atrial fibrillation.
That is an excellent answer, Logan. Atrial fibrillation is an irregular heartbeat, which happens because the left atrium gets very, very stretched, and the electrical wires inside the left atrium, they get warped, and short circuits develop, and then the heartbeat becomes quite irregular. And And the atria, which are the two top chambers of the heart, they don't contract anymore. They just kind of quiver. Luckily, it's the two bottom chambers of the heart, the ventricles, which are the main pump houses. So the atria are usually like a 5 to 10% bonus. But if they only quiver and they don't contract, blood tends to stagnate in the nooks and crannies of the top chambers of the heart. And whenever blood stagnates, we know that small clots form. And usually these clots, if they sit there and do nothing, no problem. But life's not like that, and these clots can fly up in the circulation and they can go anywhere. Not too much of a problem if it goes to our arm or a leg, because we can fish it up with a kind of operation. But if it goes northwards, well, we don't want it to go northwards. That's why if you have atrial fibrillation or mitral stenosis, you need to be on blood thinners like warfarin or equivalents to prevent strokes from happening. Okay. Your presentation was excellent. You went very, into great detail about rheumatic fever and how we can present it. You presented a global overview that the poorer countries, you see it more. You don't see it very much in the United Kingdom. And of course, there's a lot of work to be done to try and even things out in the world, isn't it? But thank you for your presentation.
Thank you, Dr. Mitra. It was very nice to hear those comments, and the presentation was good as well. Now, I'll talk about the charity that we have come in contact with. It's called the British Heart Foundation, and we'll also put a donation link in the Google Meet chat. So here we go. So any donations would be welcome, and we would promote that as well. And so now we'll have a lunch break, and we'll come back at 1:05. Hope you enjoy your lunch.
Hello, everyone, and I hope you've had a good lunch. We'll probably be starting back soon in about 1 minute if Group 3 are ready to present. I hope everyone has had a good lunch and is enjoying the day so far. We have Group 3 now, and then shortly afterwards we'll have a presentation, and then afterwards we'll have an ethical discussion and give us a chance to interact with you. So see if Group 3 would like to start sharing their screen now. Cardiomyopathy. Thanks.
Cardiomyopathy by the Tuminators. An overview of the disease. Cardiomyopathy is a general term for the disease of a heart muscle, where the walls of the heart chambers have become stretched, thickened, or stiff. Cardiomyopathy mostly affects the muscles of your heart's main pumping chamber or left ventricle. As a result, your heart can't pump blood effectively to the rest of your body. It is often inherited, but it can also be caused by other heart and circulatory conditions.
The pathophysiology of cardiomyopathy. Cardiomyopathy is a disease of the heart muscle. Cardio refers to the heart, myo refers to the muscle, and pathy comes from the Greek word pathos, meaning suffering or disease. Cardiomyopathy is defined by the World Health Organization as disease of the myocardium associated with cardiac dysfunction. This is a broad term, however. It is often distinguished from other heart diseases when in a clinical setting. Heart diseases such as ischemic heart disease, where the coronary artery is blocked, and valvular heart disease, where a valve in the heart itself is damaged. Cardiomyopathies can manifest with various structural and functional phenotypes and are frequently genetic. So basically, cardiomyopathy is a disease of the heart muscle, hindering its ability to pump blood around the body. There are four main classifications of cardiomyopathies: dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. However, cases do arise that do not readily fit into those categories, and so there's a fifth unclassified grouping. Firstly, I'm going to talk about dilated cardiomyopathy. This type of cardiomyopathy is characterized by dilation and impaired contraction of one or both ventricles. The ventricles are the stronger two of four chambers of the heart, the left ventricle being especially important as it is responsible for pumping blood at a force large enough to reach all around the body. In fact, it is the most muscular part of the heart for this reason. A heart with dilated cardiomyopathy has an enlarged ventricle, and you can see on the diagram on the slide. And what this does is impair the systolic function of the heart and lowers the efficiency that blood can be passed from the atrium to the ventricle. The ventricle is also weakened, hindering its ability to pump blood at the pressure required. The enlarged ventricle can also cause increased cardiac mass. Next, I'm going to talk about hypertrophic cardiomyopathy. Hypertrophic means an enlargement of an organ, which can be seen in the diagram here. The septum is larger in the second heart, showing a smaller volume of blood in the left ventricle. And the majority of the time, this is the case. However, it is possible for it to be of the right ventricle. Now, hypertrophic cardiomyopathy is often a genetic disorder caused by the mutations in cells. However, it can also be developed in response to prolonged intensive endurance training. This training can cause an increase in the ventricle wall thickness, cavity size, and mass. This is known as athlete's heart. Restrictive cardiomyopathy is characterized by non-dilated ventricles, but with impaired ventricular filling. This is due to the heart muscles becoming stiffened, less flexible, and less ready to be expanded to fill up with blood between heartbeats. This is actually the least common of the four types of cardiomyopathy, but can occur at any age. In restrictive cardiomyopathy, hypertrophy is typically absent. However, in certain cases, such as a storage disease like Fabry disease, there can be an increase in the left ventricle wall thickness. Systolic function usually remains normal in the earlier stages. However, it can be impacted as the disease worsens over time. Arrhythmic cardiomyopathy is when the contractions of the ventricles are out of sync with the pumps of the atria. It is defined as an arrhythmogenic heart muscle disorder with structural abnormalities to the myocardium with clinical presentation of arrhythmia. It is important to note that the definition includes that it is not explained by ischemic, hypertensive, or valvular heart disease. It is usually observed in the right ventricle, called arrhythmogenic right ventricular cardiomyopathy, ARVC, and it can be caused by the right ventricle developing a fatty, fibrous tissue due to mutations in the cell. This tissue is a worse conductor of the electrical signals passed through the heart, causing the asynchronous contractions. This lowers the output of blood from the heart, causes a backup of blood in the circulatory system and a buildup of fluid in soft tissues and lungs. It can also lead to heart failure. Lastly, unclassified cardiomyopathies. The term unclassified cardiomyopathy was only included in the 2008 ESC classification system, much later than the previous four. It is included to describe those cardiomyopathies that do not readily fit into the rest. An example of these unclassified cases is stress-induced cardiomyopathy or hypertension cardiomyopathy. There is systolic dysfunction in the heart due to left ventricle expanding and rounding off, as seen in the diagram. This is observed to be caused by intense stress, for example, an immense loss. For this reason, it can be known as a broken heart.
Causes of cardiomyopathy. Often the causes of cardiomyopathy is unknown. Sometimes it is acquired, meaning the result of another condition, and sometimes it is inherited from a parent. Certain health conditions or behaviors that can lead to acquired cardiomyopathy include long-term high blood pressure or hypertension, heart tissue damage from a heart attack, long-term rapid heart rate, heart valve problems, having previously got the COVID-19 infection, as well as other certain infections, such as those that cause inflammation of the heart, metabolic disorders such as obesity, thyroid disease, or diabetes, lack of essential vitamins or minerals in your diet, such as thiamine, pregnancy complications, iron buildup in your heart muscle, or hemochromatosis, the growth of tiny lumps of inflammatory cells called granulomas in any part of your body, including your heart and lungs, and this is called sarcoidosis. Other causes are the buildup of abnormal proteins in the organs, known as amyloidosis, connective tissue disorders, lifestyle choices such as alcohol, the use of cocaine, amphetamines or anabolic steroids, and finally, the use of some chemotherapy drugs and radiation, which are used to treat cancer. There are also other risk factors such as obesity, which can help cause cardiomyopathy.
Diagnosis: the identification of the nature of an illness or other problem by examination of the symptoms. Symptoms of cardiomyopathy usually occur in the later stages, after the heart has already weakened. They include shortness of breath or trouble breathing, especially with physical exertion or when lying down, fatigue, swelling in the ankles, feet, legs, abdomen, and veins in the neck, dizziness, lightheadedness, fainting during physical activity, arrhythmias, which means an irregular heartbeat, chest pain, especially after physical exertion or heavy meals, bloating in abdomen due to a fluid buildup, heart murmurs, which are unusual sounds associated with heartbeats. Here we have the sound of two heartbeats. One is a normal heart, and the other clip is an innocent heart murmur, so you can hear the difference. Tests done to confirm diagnosis. A chest x-ray can be used to create an image of your heart, which will show whether it's enlarged. An echocardiogram uses sound waves to create images of the heart, which show its size and its motions as it beats. This test checks your heart valves and helps your doctor determine the cause of your symptoms. A thin tube is inserted into your groin and threaded through your blood vessels to your heart. Pressure within the chambers of your heart can be measured to see how forcefully blood pumps through your heart. Cardiac MRI scan. This test uses magnetic fields and radio waves to create images of your heart. Your doctor might order a cardiac MRI if the images from your echocardiogram aren't helpful in making a diagnosis. Several blood tests might be done too, including those to check your kidney, thyroid, and liver function, and to measure your iron levels. One blood test can measure B-type natriuretic peptide, a protein produced in your heart. Your blood level of BNP might rise when your heart is in heart failure, a common complication of cardiomyopathy. Most types of cardiomyopathy are inherited and are seen in children and younger people. If you've been diagnosed with an inherited type of cardiomyopathy, you may be advised to have a genetic test to identify the faulty gene that caused this. Your relatives can then be tested for the same mutation, and if they have it, their condition can be monitored and managed early.
Complications of cardiomyopathy. Often, cardiomyopathy can progress into other more serious complications. The first is heart failure. This is because your heart can't pump enough blood to meet your body's needs. Untreated, heart failure can be life-threatening. The second is blood clots, otherwise known as emboli. Because your heart can't pump effectively, blood clots might form in your heart. If clots enter your bloodstream, they can block the blood flow to other organs, including your heart and brain, which is also life-threatening. Therefore, another complication is a stroke. The third complication is heart valve problems. As cardiomyopathy causes the heart to enlarge, the heart valves might not close properly. This can cause blood to flow backwards in the valve. The fourth and final is cardiac arrest, which can trigger abnormal heart rhythms that cause fainting, or in some cases, sudden death if your heart stops beating effectively.
Ethical concerns. Here's a quick recap of the 4 pillars, which are autonomy, meaning patients have free choice and ultimate decision-making ability; justice, where all treatment should be in compliance with the law and the patient's rights; beneficence, all doctors have the moral duty to provide treatment which is the best interest of their patients; non-maleficence, Doctors are obligated to do no harm when treating patients. Regarding cardiomyopathy, it was relatively difficult to think of an ethical concern around the diagnostic process, treatment, or general patient care. However, this particular circumstance is surrounding an elderly patient suffering from heart failure with an implanted pacemaker, whose health is rapidly deteriorating. Their health has reached a point in which it has caused them unable to speak directly with their doctor, although they had communicated with their next of kin that they did not want any medical intervention or therapy that would prolong the dying process. This case asks whether a pacemaker can be deactivated to prevent unnecessary prolongation of life. Every person has the right to refuse medical interventions or to request their withdrawal, and the rights extend to pacemakers and other technological interventions. There is no ethical or legal distinction between withholding a pacemaker and deactivating one after it has been initiated. In general, there is a widespread and accepted practice of withdrawing life-sustaining interventions from patients who are terminally ill. Although the deactivation of devices such as pacemakers occur with less frequency, the ethics surrounding the decision remain the same. The need to respect the patient's autonomy applies whether a life-sustaining device is internal or external to the body.
Current treatment for cardiomyopathy. The goals for treating cardiomyopathy are to stop the disease from getting worse, manage the conditions that cause or contribute to the disease, reduce the complications of the SCA, sudden cardiac arrest, and control the symptoms, restoring as much quality of life back into the patient's life. Lifestyle changes can include a healthy diet and physical activity. A healthy diet would consist of a balance of fruit, vegetables, and grains. At least half of these grains should come from whole grain products, for example, oats and wheat. Foods with high saturated and trans fats should be avoided. For example, having leaner cuts of meat, low-fat dairy products, and cutting out most chocolate and fried food from your diet would decrease the amount of saturated fat that the patient is consuming. Ensure you do not add too much salt to food when cooking or buying foods too high in salt, as a high intake in salt can lead to high blood pressure, increasing the risk of cardiomyopathy. Avoid drinking alcohol or drinking any beverage with too much sugar or sweetness. Increase the patient's physical activity as much as you can, ensuring that they are carefully monitored if they are taking certain medications or have any ongoing health problems or symptoms, such as pain in the chest, shortness of breath, or dizziness. There are other lifestyle changes that can help reduce the damage of cardiomyopathy, such as quitting smoking, losing excess weight, avoiding alcohol or illegal drugs, getting enough sleep and rest, and also reducing stress, especially the stress caused by school or work. There are a number of medications that can be used to treat cardiomyopathy. Doctors may prescribe medicines to lower your blood pressure, for example, ACE inhibitors, angiotensin receptor blockers, beta blockers, and calcium channel blockers are all examples of medications that can lower a patient's blood pressure. They may also prescribe medication to lower the patient's heart rate. Again, beta blockers and calcium blockers may be used for this, as well as digoxin. Antiarrhythmics are medicines that can be used to help prevent arrhythmias. It is important that the patient has a balance of electrolytes in their body. Electrolytes are minerals that are essential for maintaining fluid and pH levels in your body. Furthermore, they help muscle and tissue cells work properly. Aldosterone blockers may be prescribed by a doctor for this. Excess fluids or sodium levels may arise as a symptom for cardiomyopathy. Diuretics is a medication that can remove excess fluid or sodium from the patient's body. Medication to prevent blood clots from forming could be essential. This could include anticoagulants or blood thinners. Corticosteroids can be prescribed to reduce inflammation. In some cases, surgery may be needed. Septal myectomy is an open heart surgery for people that have obstructive hypertrophic cardiomyopathy and severe symptoms. This type of surgery is for younger patients who have had no response or improvement in their condition from their medication. The procedure involves removing part of the thickened septum that is bulging into the left ventricle. This improves the blood flow within the heart and out of the body. Implanted devices may be needed to make the heart work better. These can include a pacemaker, which uses an electrical pulse to prompt the heart to beat at a regular rate, a cardio-resynchronization therapy (CRT) device, which coordinates the contractions between the left and right ventricles of the heart, a left ventricular assist device (LVAD) helps the heart pump blood to the body. It is very helpful as it can be used as a long-term therapy or a short-term solution for a patient awaiting for a heart transplant. Doctors may implant an implantable cardioverter defibrillator, ICD, which helps maintain the normal heartbeat by sending an electrical shock to the heart if arrhythmias or irregular heartbeat is detected. Heart transplants can be carried out where a patient's diseased heart is replaced by a healthy donor's heart. However, this would be the last resort for a patient who is believed to be in the end stage, where all other treatment has been explored but there has been no success. Alcohol septal ablation is a non-surgical procedure where a type of alcohol, most commonly ethanol, is injected into a small artery that supplies blood to the area of the heart muscle thickened by the HCM. The alcohol causes the cells to die, shrinking the tissue to a normal size and improving blood flow. This is a preferred option for older patients as the risks and complications of surgery are not a factor, especially as these risks and complications increase with the age of the patient. How can cardiomyopathy be prevented? Unfortunately, cardiomyopathy can be inherited, and there is no way to prevent this. However, just because you have inherited it does not mean that in every case you can go on to develop it. And there are ways in which you can reduce the risk of you developing the condition. Trying your best to reduce the chance of getting heart disease, high blood pressure, and a heart attack will also in turn reduce the risk of you developing cardiomyopathy. It is important that you diagnose and treat any underlying conditions as quickly as possible. This can be done by going for regular checkups with your doctor, especially if you have any worrying symptoms. Listen and respect any of your doctor's advice on lifestyle changes. Often these may be hard to implement into your life, but it could potentially save you from developing cardiomyopathy. In addition, take medications exactly as prescribed by your doctor. Thank you for listening. Any questions?
Thank you to the speakers for your presentation. And now we're going to hand over to Dr. Mitra for his feedback.
Thank you very much. I really enjoyed that presentation. So congratulations, all of you. I've made a few notes. Rowan, congratulations. You spoke very well at the end. You gave a very detailed overview of the treatments. You mentioned how cardiomyopathies, are inherited. You can choose your friends, but you can't choose your parents, as they say. You've talked about ICDs and the way they deliver shocks to essentially like a slap on the wrist to the heart, saying behave yourself and go back to the normal heart rhythm and prevent sudden deaths. Can you tell me, what could be available in your own locality or wherever you are in a public place, which can do the same thing as an ICD?
I'm not quite sure.
Something you may have noticed on the walls of streets or stadiums or public places?
Would it just be any electrical wires that you could find?
Anybody in the audience? Anyone?
Defibrillator?
Correct.
AEDs.
Well done. Well done. AED, and these are external defibrillators as opposed to the ICD, which is an internal, defibrillator, which we actually implant. Very good. These are life-saving devices. You don't need any special training to do this. You open the box by pressing a number. You take the gadget out. It tells you exactly what to do. You put the pads on the patient's chest, and you wait for the gadget to analyze what's going on. They'll say, press this button or not, okay? And if it says recommend shock, you press the button, and you press it, and you can save somebody's life. And that's how nowadays, you see in all the stadiums, you have all these AEDs, everywhere, because very often you hear about footballers collapsing on the pitch or athletes collapsing on the pitch. These AEDs are life-saving. And this is because these people have hitherto undiagnosed cardiomyopathies, and despite our fabulous science, we can't detect all of them, and sometimes they escape. Somebody mentioned athlete's heart, very important, and that's if you train, your heart muscle will become thick, and then it sometimes becomes very difficult for us heart specialists to know whether this is simply because of training, athletic training, or whether there's an intrinsic problem in the heart muscle itself, which can lead to sudden death. And the only way to do it is sometimes to say to the athlete, stop training for a while, and then we'll rescan you, and then find if the heart muscle has gone back, then we know it was athletic training. But if it hasn't, then we know it's a cardiomyopathy. Athletes hate us, telling them that, because they don't like detraining, at all. Let me see, Matthew, congratulations for actually pronouncing B-type natriuretic polypeptide. Well done for that. You gave quite a good detail. You were very clear in your presentation. You harped on the symptoms. Harshita, you were very clear, and you spoke about sudden cardiac death. So that was very, very good. One of you mentioned something called a heart murmur. Can anyone tell me anything about heart murmurs?
Is it like background noise coming from your heart?
Actually, one of you actually put the slide up where you played a little clip of a normal heartbeat and a heartbeat which has a whooshing sound in it. Not just a lub-dub, lub-dub, lub-dub. You played a sound which is whew, whew, this kind of sound inside the heart. Essentially, any kind of whooshing sound inside the heart, which you can hear through the stethoscope, is a heart murmur. And this happens because there's turbulent flow of blood inside the heart. Now, whether this turbulence is caused because there's a hole in the heart somewhere, or whether the heart valves are leaking or flared up, or simply because there's too much blood rushing around, you have to diagnose by another means. But yes, a heart murmur is often a sign that there is something going on inside the heart, that there's a problem in the heart valve, or there's a hole in the heart, something like that. But on the whole, excellent presentation, very thorough, and I really enjoyed myself. Thank you. I think it's incredible that you guys, who have no formal medical training, are giving presentations to such high standards. Perhaps you don't understand all the nuances there, but really the way that you guys are doing research, I can tell you that certainly South Wales is going to be a better place because you guys are around in our future. So thank you very much for having me. Aryan, I'm very happy to answer questions, and I'm also very happy to, if you wish, and only if you guys wish, to do a small presentation on coronary disease. I know it might be encroaching on your time. If you don't want that, that's fine. But otherwise, thank you very much, and I'll be leaving shortly otherwise. Thank you so much.
No, thank you for those comments. They were great. Feel free to present this presentation. I think we can accommodate that and have a little short change last minute on the timetable. So just to explain to everyone, maybe Dr. Mitra can go through his presentation, and then afterwards we can have the open ethical discussion, as we still have that 30-minute break that we can use. So yeah, feel free to make this deliver this presentation, because the worst thing that for me would be that your work is wasted in any way. So I'm happy to accommodate anything that you're willing to provide. So feel free.
No, my work is not going to be wasted. It's just it was just a few simple things. Only if people want it. But if people want to go for another extended lunch, feel free to do so. I haven't used this particular platform before, so you'll have to bear with me on this sharing the screen business. I guess it's like it might be.
Yeah. So
Should it be present your entire screen?
You can present. It depends where your presentation is. I think
it's on my desktop.
Okay, I think presenting the entire screen and then presenting
Okay.
the presentation should be fine.
Okay, I'll try this now. If it doesn't work, I can always revert. Can you guys see the screen?
No, unfortunately.
Okay, hang on for a second. How about now?
Yeah, that's worked. Yep.
Is that any good?
Yep, that works.
Excellent. So here's a few slides on coronary disease, which is a big killer, one of the biggest heart disease killers. Okay. Now, essentially, what happens is that as we get older, or if people do things like smoke or drink too much, or get diabetes, or have a high cholesterol, or have a bad family history of people having heart attacks at a young age, or if they have, for example, belong to a certain, certain ethnic backgrounds, you can have furring up of your arteries. When you're born with a nice, clean artery, but as you get older, cholesterol keeps getting deposited in the lumen of the artery, and then this lumen of the artery becomes thicker and thicker and thicker with lots and lots of plaque. Okay, and inside the heart, there are, well, or rather on top of the heart, there are three of these arteries, three of these main coronary arteries, and they feed the heart muscle with blood. Okay, I'll come back to that slide in a second. Okay, and so if you see the picture of the CT scan of the coronary arteries, on the top left, you'll find these little white worms are the arteries which sit on top of your heart and feed with blood. Although the heart pumps blood to the rest of the body, it itself needs blood to survive. And that's because blood carries oxygen and blood carries food and feeds the heart muscle. And if these pipes get furred up or blocked up, then not enough blood goes into the heart muscle, and the heart essentially shouts in pain. And this heart pain is called angina pain. And on a scale of 1 to 10, 1 to 4, we'll call it angina. 8 to 10, we'll call it a heart attack. And there's a bit of gray area in between. So in angina, the arteries are just furred up. And that means there is still some blood flowing down the pipe, although there's less blood than you would like. It's like driving a car, but the fuel jets are narrow. So when the car is going very slowly, the revs are low, there's still enough petrol going in the engine, the car is going at 10 miles an hour, there's no problem. But, so you and I are sitting here at rest, we're not doing much, the heart is going 60, 70 times a minute. Even if the arteries are furred up, there's still enough blood going into the heart muscle and no one gets any chest pains. But somebody who has furred up arteries, okay, if they start doing some kind of exercise, the brain is going to tell the heart, pump faster, the rest of the body needs more blood. And the heart starts pumping faster. And when that happens, the revs rise, the car is going at 70 miles an hour, the engine is sputtering because not enough petrol is going into the engine because the fuel jets are narrow. That's what causes heavy feelings in the chest pain. And then if you slow down, stop doing whatever you're doing, the heart calms down, the revs fall, the imbalance between demand and supply goes away, and this pain goes away. And this is called angina. Angina and a heart attack are part of the same disease spectrum. In angina, it's just furred up. In a heart attack, some of this gunk actually breaks off and then blocks up the artery. And therefore, a part of the heart muscle doesn't get any blood and there's more permanent damage. And that's called a heart attack. Okay. And there are many ways we want to find out if somebody comes to you with chest pain. We have to try and find out in some kind of ideally in a non-invasive way, whether the coronary arteries are good or not. We can use special scans for that, or make people run on a treadmill with ECGs on, or we can get a CT scan of the heart, which is more modern. We can also put in tubes inside the heart and take some pictures, which is called a coronary angiogram. Okay, but essentially the tablet is essentially the treatment essentially is the same. It's a plumbing problem. Let's say your kitchen sink is not draining very well because the pipe is partially blocked up. The water is flowing slowly. You can go and buy some pills from B&Q and chuck it down the drain and see whether that'll improve things. So tablets. You can call a guy like me who will go in with a special brush into the coronary arteries through your arm, through via tubes, and then use some balloons to clear the blockages and leave some stents behind called scaffolding, and that to improve the flow. That's called having an angioplasty. Or you can call an open heart surgeon, a different kind of plumber, to actually change the kitchen pipes. And what the surgeons do, they take a strip of vein from the leg, which they use as a pipe. They take a redundant artery from the chest, which they use as a pipe. They connect one end to the mains, which is the aorta. The picture you'll see where the tube is in red. And they'll connect another end of the pipe to the coronary artery, but beyond the blockage or beyond the narrowing, so you can get blood. So that's called coronary artery bypass grafting, open heart surgery, essentially. So pills, balloons and stents, or open heart surgery. This is how you treat, coronary disease. This is where we normally treat them, with angioplasty in a cardiac catheter lab, where there's an X-ray table. There's a big X-ray, camera which puts up the picture on a big television screen for us to see. You can watch Sky Sports on that television as well when you're not doing any cases, so it's very useful. And this procedure is helped by somebody who operates the X-ray, at least 2 nurses who are helping you, and a cardiac physiologist who sits behind the X-ray screen, who is monitoring the patient. Lots of things happen here besides angioplasty. We've mentioned TAVI before with valve, implantation, and also it's also a place where we treat heart rhythm disturbances by burning out the bad electrical short circuits inside the heart with either cold energy or with radio energy. That's what the coronary arteries look like. We can only see the big ones, the motorways. We can see the A roads, but we can't see the B roads and the C roads. So we have to manage narrowings in the tiny arteries with tablets. With the big arteries, we can manage it with balloons and stents or with bypass operations. Here's a case which I did a few years ago. So, a lady had come to me, suffering exertional chest pain, which I diagnosed to be angina, and you will probably see that there is a worm which is going from the left to the right, from the left upper to the right lower, and that's one of the main coronary arteries of the heart, the left anterior descending artery, and somewhat in a third of the way from the top, there is a severe narrowing where there's a small branch which goes downwards, and I've put a stent in there, and this lady is doing very, very well. So here are my take-home messages for coronary heart disease. Number 1, if people are complaining of chest pain, you got to think, does this person have coronary disease? In which case, you've got to try and flag it up. You got to understand what causes coronary disease and modify your risk factors. So, if you know people who smoke, this is not a good idea because it's a rapid accelerant of atherosclerosis, which is the process by which the artery flares up. Get your cholesterol checked, check for diabetes, look for family history and your lifestyle, and spread this understanding. So thank you very much for having me, and that's the end of my presentation.
Well, thank you for that presentation. That was very informative and certainly something that we all, I definitely enjoyed, especially the Sky Sports watching on the TVs. Anyway, thank you for coming to this session. I hope it's been helpful for you to interacting with the students, and I'm definitely sure that all the students have gotten some positive feedback on the presentation and delivery skills. So is there anything you'd like to say before?
I really enjoyed my time with you guys. I really think that this country is in good hands. So thank you guys for being around, and thank you for your interest in medicine. It's a very fulfilling career. It's you never look back. It's a career where you give a lot and you receive a lot, and you'll never be bored with it, whatever you do. And of course, you guys have the drive to go out and do and be successful in whatever you do. Before I go, I'm happy to answer any questions if people have. If there are any questions of any sort, I'm happy to answer that before I go.
Doesn't seem like there's any questions. Does no one have any questions? No? Okay. All right,
Well, thank you for having me.
No,
Enjoy the rest of the day. Bye-bye now.
Right. Thank you. Okay, so now we'll start our ethical discussion within our break, since that we've had this important presentation come in the way, which was useful. But I think we'll have to overrun a break, which is fine. But let me share my screen so we can start with this. This is an opportunity for you guys to interact with us and hopefully for us to try see how you think, because in medicine, there's something that everyone has to talk about is ethics. So give me one moment, please. All right. So I hope everyone is having a good day so far. As a result of some extra time, we've decided to try make the session more interactive, as I just said. So we feel that medical ethics is something that's recurring in everything in terms of medicine, in terms of UCAT, your BMAT, in the essays, in medical school, you'll learn more about it. And obviously in your future practice, when you'll come across medical ethics when coming across patients. So some information before we start. So just like I said, we hope this allows you to interact with us, as you must remember that we are also students, hence we don't fully know the ins and outs of medicine. However, we hope that we can take something like ethics and open up some sort of discussion as to how a doctor should act in certain scenarios. There's no clear right or wrong way of dealing with certain patients when considering medical ethics. However, there's guidance that we should be aware of from the GMC, which all doctors are obliged to follow. So, before getting into this discussion, I wanted to address a little bit of background knowledge with you guys. I'm sure a lot of you attend some medical ethics society, whether that is in your own school or externally. In such societies, they tend to focus on the more prima facie of medicine, which is a principle which basically says a principle is binding unless it conflicts with another moral principle. If it does, we'll have to choose between them. Essentially, these are the fundamentals of our medical ethics. These 4 principles suggest that patients have the right to make decisions about their health, and as a doctor, you should provide the best treatment without causing harm that is accessible to all. I'm sure you're all well aware of these, so I'll focus on the other theories. Confidentiality is such a big topic in the field of medical ethics, as there is so much collateral damage done on the basis of confidentiality breachings. This is a doctor's pledge not to disclose information to a third party, not involved in the care of the patient, hence ensures trust between the doctors and the patient. There is an implied promise and maintains virtue ethics in the way that a patient has faith in their doctors, in that their doctor is virtuous and respects their confidentiality, as they should in a profession like medicine. The doctor must understand the consequences of such breachings, such as mistrust in the field, resentment, and in turn could affect the patient medically. The GMC states that there are certain scenarios where doctors can breach confidentiality, such as harm to the public in order to release statistics, or giving information between healthcare professionals, and obviously with the patient's consent. If confidentiality is breached, the GMC states we follow the duty of candor, and basically we must record it and make sure that the patient is well aware that their confidentiality might be at stake, and people might know that they weren't intending on. So medical ethics links nicely to our philosophical values about life. Duty-based ethics is dependent on the morality of doctors, and hence states, an action is right and only right if it is in accordance with a moral rule or principle. These can include theological morality, reasoning, and some actions that are rational to everyone. This is why most universities will not accept students with a band 4 in situational judgment, as they do not express the morality needed in the career of medicine. Utilitarianism can be linked to consequentialism, as it states an action is only best if it has the best consequences. However, this concept is also important when considering finances, delegation of resources, and essentially to maximize the happiness a patient experiences. Finally, the doctor-patient relationship is something that is upheld in medicine. The doctor should be able to adapt to the patient's needs to provide them with the best healthcare possible. Firstly, a deliberative model allows the doctor to challenge the patient's views through discussion to steer the patient towards the best presumed interests. Here, a doctor can be viewed as a friend. The interpretive model is slightly more developed, where the patient is advised by the doctor on their views, and hence their autonomy is respected. The paternalistic model contrasts this, as it respects beneficence more than autonomy, allowing the doctor to override the patient in terms of what is in terms of the treatment plan, which is in the patient's best interests. So this model is generally only used if the patient is unsure and simply says, "Oh, let my doctor decide what is best for me," or if the patient is a child and looks to the doctor for a paternalistic view. Or we can look at, lastly, the informative model, where all treatment is based on facts and figures, where the doctor is simply the expert in the scenario. Whilst autonomy is upheld, beneficence could be reduced slightly, as the patient's best interests are not always in mind here. They should be in terms of all medicine. However, in the informative scenario, it would simply be the doctor giving out the information to the patient, telling them what they think is the best option, but not trying to get them to do the best thing that would be for them. It would simply be giving information and expecting the patient to give an answer. So now for the interactive situation of this section, I wanted to ask, do you think euthanasia should be allowed in the UK? I mean, currently it's illegal. So what are your thoughts about this? Anyone is free to turn on their mic and talk about it. And yeah. Anyone? Okay, does the committee have anything to say?
I think no.
What do you think, Todd?
Wait, what do I think again? No, I think yes. Sorry.
You think it should be allowed?
Yeah.
All right.
But there should be loads of regulations and like things that person has to like tick to get it. Otherwise, because they're living a very poor quality of life if they want to get euthanasia. And so to prevent them committing suicide themselves, I think it should be allowed.
Yeah, I mean, we've touched on euthanasia a little bit. Oh, well, with the ethical concern that Group 3 mentioned. And it's important to realize that there are different types of euthanasia. You have active, passive, voluntary, and involuntary. So, I mean, they're kind of self-explanatory what they have. But good answer. I wouldn't, with any ethics question, there's no straightforward answer. So, I mean, it's good to balance up what kind of things would be good and bad in that scenario. Obviously, with euthanasia, you got to I did a talk on this actually when I was younger for my English GCSE, and I explored the ambiguity of certain ideas in the Hippocratic Oath, where obviously our ethical principle of non-maleficence could be misconstrued as, what is more harmful, allowing a patient to live the rest of their lives on the delirium of morphine, or simply allowing them to take their life and stop suffering. So I guess that's something that could be considered. Is there any other thoughts to do with euthanasia? Anyone on the committee? Nope. Okay, well, we'll move on to the next one. So, do you think the NHS should purchase expensive treatments for rare diseases? I mean, there's a lot to consider about this one, like whether certain diseases are variable or whether they should be given enough attention as they do. So, does anyone have any thoughts about this? The whole point of this discussion is to make sure that we're getting enough points across and making sure that people understand what's being said. So again, I'm just giving you the topics, seeing what you think. So what do you think about this?
I think it depends on the NHS's ability to prioritize. Given if they have shown evidence that they're capable of like handling like basically common diseases, then I think it's a good indicator that they should purchase treatment for rare diseases.
Okay, but good answer. But I'd ask another question on that. Would it, if the NHS decided to give treatment for one rare disease, wouldn't a minority of people who'd be affected by another rare disease see that as maybe favoritism, or not even favoritism, just like unfair or unjust by the NHS? What would they do in that situation?
The NHS can justify by releasing data on like the diversity of rare diseases. So like among rare diseases themselves, there's probably a classification of there's probably the spectrum of most rare and least rare. So I think they can use that.
No, yeah, exactly. That's what I was trying to infer on. It's important to understand that the NHS needs to treat society as a whole, and hence, as you said, like there's a spectrum of certain diseases. Obviously, the NHS does not have infinite money, and hence cannot treat every single disease. But it's that idea of trying to see which ones would serve the population as a whole better, and which treatments would be better in a larger group. So yeah. So next one. This one is a very common MMI question. Should you inform a 14-year-old's request, parents about their child's request for contraceptive pills? Anyone have any thoughts about this?
No.
No.
Because if a 14-year-old is responsible enough to come to a doctor about contraceptive pills, then they're obviously, well, put it this way, they're more responsible than those who are still having sex and yet not using any kind of regulation of contraception. So the fact that they were able to take responsibility and that informed that they came to a doctor and put their trust into a doctor to provide them with contraception, I think to then tell that child's parents would breach the trust between that child and the doctor, and may also disencourage the child from using contraception.
Mm-hmm. No, great answer. I mean, you've touched on it already, but we you're talking about autonomy and that whole idea of trying to make sure that the doctor gives the best treatment available for the patient. And in this scenario, as you said, the patient is clearly able to make decisions for themselves. And so as a doctor, you should see that as them being competent. And this also relates to something that we should be aware of when applying to medical school, something called Gillick competence. And you can read about it. I have a little bit of knowledge about it. It's simply just, although the age of consent in the UK is 16, the doctor can demonstrate if the doctor can see if a patient has competence after a certain age. And hence, yeah, I think not allowing the parents to know about this is fine. But here's a separate question that I've just come up on while talking. What if the doctor suspected sexual abuse? What would be, how would that change the ethical scenarios in this? Anyone have any thoughts?
I feel like the doctors should also include the parents in this, since the parents should know what's happening to their own child, since they have input on child's health as well.
Yeah, no, exactly. The doctor must be able to make sure that the child is under all necessary protection guidelines. So hence, if the GP simply believes that the safety or well-being of patient is at risk, they must follow the child protection protocol. And this would be in the best interests of the patient in this scenario. So they must see whether anything is concerning about the scenario and whether the patient is being taken advantage of in any way. So I have 3 more questions after this. 2 are BMAT questions. So I thought for all of you year 13s here who are currently preparing for their BMAT examinations, I'll give you some BMAT essay questions. So feel free to just say a point or 2 that you have when thinking about this. So when treating an individual patient, a physician must think of the wider society. I think we've touched on this a little bit earlier. So what do you think of this? What's the positives and negatives of this scenario? Yeah, again, this is open to everyone, not just year 13s. I mean, it would be great if anyone younger years can actually answer these. It would be a good head start on your BMAT preparation. I mean, again, there's no right or wrong answer. It's just talking about what you believe and what you think is important.
You could look at it like 2 ways. So firstly, you could look at it in terms of justice. So everyone deserves kind of equal treatment. And so it's like, well, if you didn't provide like one particular treatment for one person because you didn't think that they qualified, then should you provide it for another person? Like, who are you to say who should and shouldn't receive the treatment, like justice wise? But then also each patient is individual and has their own specific needs. So you may not need to think of the wider society, because in that moment, you're not trying to help the wider society. You're trying to help that one person who has come to you specifically to help them with their problem. So you could look at it in more than one way.
Yeah, no, that makes sense completely. I have nothing more to say to that. I think you've explained that properly. I wanted to touch on something here. I'm not sure if anyone knows, but does anyone know of of a doc or an ex-doctor named Harold Shipman?
Yeah.
Yeah. How could that scenario be like taken about in this topic? Do you have any idea how you can like talk about that in an essay? Okay, so in a BMAT essay, it's important to argue both sides. So when arguing that the doctor should only consider the individual that he or she is treating at that time, you might think of Harold Shipman. What did he do? He basically killed approximately 200 patients, elderly patients, by injecting them or going to their houses and as a doctor, as a traveling doctor. And he did this for all the patients to make sure that he wouldn't be caught. So it's the speculation around this, but the unethical reasoning behind his motives for that matter is to reduce the burden of the NHS, which is weird in its own way, but it was weirdly thinking of the broader aspect of society. And I'd like to say that doing something like that is completely unethical, and hence thinking about wider society is not good like that. Obviously, I don't need to express that. So that's how I would talk about Harold Shipman a little bit. Maybe go into the uniqueness of patients. Okay, second BMAT question. Can doctors take strike? Is it ethical for a doctor to decide when to take strike and simply hold placards outside the hospital and demand different changes to the workplace? Is that ethical? Again, I'm happy for any contribution.
I think no, because that kind of goes against everything you as a doctor should stand for. Do you know what I mean?
Yeah, what do you mean by that?
So do no harm or do good. If there are sick patients that need looking after, and you're putting, if the reason for your strike, like say your salary or something above that, your first priority isn't your patient. So yeah.
Yeah, exactly. Such strikes can have the ethical consideration of non-maleficence here, like as you said, do no harm. So obviously here the patients would be it would disrupt any care for patients, and hence it wouldn't be morally acceptable in that scenario. But again, like I talked about earlier, this approach, when answering this question, you'd have to take it with a consequentialist approach. So you'd have to think about the risks and whether doing a strike would have an outcome that is justified by the means of which it's achieved. So, okay, an example, like if doctors decided to go on strike about food in the cafeteria, that is completely unethical and unjustified whatsoever. However, actually, this question refers to something that happened in 2015 to 2016, where junior doctors decided to go on strike about the new changes to their salary and their workplace hours and things like that. Again, I won't discuss that in depth, but feel free to research that when you can. But it's basically weighing up what is self-care and what is care for patients. Is the detrimental effect of working in medicine on their personal welfare affecting them so much that it's affecting the patient's welfare? Because obviously you have to put the patient's needs first in terms of any ethical discussion, right? So those two things I'd probably talk about. Does anyone have anything else they want to say?
I think, yeah, it is unethical because obviously you should be allowed to like speak up for if you think you face like sort of injustice in the workplace or if there's something you disagree with. but there are other ways of sort of showing this and communicating this in a strike, because as a doctor, it's like your responsibility to like take care of your patients and things. So like by a strike, you won't be able to do that. So you're sort of like letting the people that you are made to like protect, you sort of like letting them down, even though it's not their fault.
No, yeah, exactly. That's something that you'd have to talk about and consider when making anything, doing any strikes like this. No, great answer. Okay, now here's a question that's less ethical, but I just wanted to see what you guys think. Why did you guys decide to apply to medicine, or if any other healthcare career or science-based career? I know some people here are not doing medicine, but is anyone willing to speak up and talk about why they chose medicine? Because like again, in your interviews, you're probably gonna be asked this question. It's a very common question, but obviously a lot of people won't have strict answers. They'll probably have to prepare for it because they don't like answers like, oh well, unless you phrase it correctly, something like, I want to help people. That is such a common cliche, and that doesn't make you stand out whatsoever. So does anyone have any reasoning or anything that particularly resonates with them that they'd probably say in an interview?
I've always had an interest in the sciences and mathematics and just logical subjects in general because I find them interesting, and I've always also had an interest in biological systems, be that wider systems like environmental systems, or at smaller scales like interactions between different organic parts, organs, for example, how they interact and cooperate. And since I've always had an interest in that, I've taken up an interest in medicine in general.
No, that's a great answer. But can I ask, are you interested in surgery or just the idea of being a doctor?
I think I don't think I'm quite sure what profession I want to go into yet. I've looked into anesthesiology actually, because I'm also very interested in how foreign chemicals interact with body systems. But I do have a particular interest for interactions, I think, specifically.
Oh, okay. Thank you. No, I have considered anesthesiology before. Currently, I'm more interested in oncology simply because of the whole treating patients aspect of medicine, because I think that's more enjoyable to me. I want to do surgery too in the future, but I feel like I want to do a specialist career where I'd be spending more time with the patient and trying to make them feel as accompanied as possible. So yeah, no, good answer. Does anyone have any other reasoning for choosing medicine? Or even a specific specialty in medicine? I know some people did.
Oh, sorry. Obviously, I'm not really that sure. Like, what I want to do. I guess I was kind of interested in like psychiatry and stuff. And this is because like growing up and stuff, I was just aware there's like a really long like waiting list to get on and stuff for like certain treatment, and I think that's just like really disappointing. So so yeah.
No, that's a good answer. Yeah, I know certain people who want to go into psychiatry. Sorry. I know certain people who want to go into psychiatry simply because of the interact. Okay, simply because of the interaction between patients and doctors, and I think that's very important in medicine, because in psychiatry you see a wide range of patients. I've also considered it before, but I guess I want to do something more with my hands. I'm just giving you my opinions and what I think. So yeah, again, I'm just a year 13 student, and I'm definitely not as proficient as certain medical specialists, but I hope that this session has been a little bit more helpful for you, and given you a little taste of what certain questions might be in university, or even in your future studies when you come into year 13 or over the summer. So are there any questions that maybe someone will like to ask me specifically, or the committee? Okay, so yeah, thank you for listening to this presentation. It's a different kind of thing that we've introduced this time. I hope that it's been helpful to some extent. And I think we can have a short, how long do we have? I think we can have a short break, 7 minutes-ish before our next group. So feel free to come back at 20 past. So thanks. Hello? Is everyone here? Okay. Does group 6... Wait, give me one moment. Hi guys, I hope you guys are okay. Does group 6 want to start presenting? Their topic
Yeah.
is Brugada syndrome.
Right. Hi. Can you guys hear me? And can you guys see me?
Yep. Yep.
Right. Thank you. Okay. So hi guys, my name is Wani, and today our team, consisting of Frida, Amira, Mabel, and I, will be talking about Brugada syndrome. So here is just a contents page so that you guys know what we're going to be discussing. So there's an intro, there's something about pathophysiology, diagnosis, treatments, ethical concerns, and some notable cases that you guys can feel free to read after our presentation because it is a bit lengthy, innovations and analytics. So what is Brugada syndrome? Brugada syndrome is a disease brought about by genetic defects that causes dangerously abnormal heartbeats brought about by sodium channel mutations. And this will be further discussed in the upcoming slides. Passing over to Amira.
Yeah, hey guys, I'm going to do the pathophysiology behind the Brugada syndrome and just talk about basically the causes. So how does this condition come about? Basically, the genetic form of Brugada syndrome is most often caused by a defect in the genes, and that's like the overall cause. Most of these mutations are inherited by their parents to the children, and that means that only a single copy of an abnormal gene is necessary for the appearance of disease in an individual. Most individuals with the disease also have an affected parent, and each child of an affected individual has a 50% chance of inheriting the genetic variation, which is quite a big probability, and it doesn't matter about the gender or sex of the individual. So basically what that means is if other family members have had the Brugada syndrome, the risk is very likely for you to have it. But there can be also other causes, so it doesn't necessarily have to be inherited. It can be developed later on in life. These defects cause malfunction in sodium channels in the heart muscle cells, and that leads to abnormal heart rhythms. And so I'll be now explaining the biochemical systems and physics behind this condition. So as we know, guys, the heart has 4 chambers, the right atrium, the left atrium, right ventricle. And so there are electrical impulses that cause the heart to beat. And the conduction of electric signals is made possible by special, sorry for the background noise, by special molecules called ion channels, which govern the movement of the negatively and positively charged particles. And with Brugada syndrome, these ion channels don't function properly due to specific genes, which I'll explain in the next slide. The electrical impulses between the ventricles become uncoordinated, and that condition is also called VF, so ventricular fibrillation, and that results in a decreased blood flow to the brain and the heart. And on the left is a diagram, basically a simplified diagram, which just describes the electrical system of the heart and where the impulses take place. So, again, more than 250 mutations are associated with Brugada syndrome, and you could see it on the right on the diagram, and they're reported in 18 different genes. So the most common gene that is associated with the syndrome is SCN5A, and almost 15 to 30% of affected individuals have this specific mutation in the gene, so it's very common, and that is located on chromosome 3. This gene is responsible for the production of a protein that allows movement of sodium atoms into heart muscle cells through a channel called the sodium channel, as described before. And so abnormalities in the SCN5A gene specifically change the structure or function of the sodium channel, and thus results in a reduction of sodium ions into the heart cells, which can be fatal. So when we have this mutation, we need to understand properly the effect that this mutation has. This type of ion channel plays a critical role in maintaining the heart's normal rhythm. So this disruption in ion transport alters the way the heart beats, and that once again leads to abnormal heart rhythm. Because quite simply, your heart doesn't pump enough blood into the rest of your body, and you can faint if the rhythm lasts for a short time, but it can lead to sudden death. This was an interesting information I found when researching, but the SCN5A gene mutations are also associated with the long QT syndrome type 3. And that is basically another form of a heart rhythm abnormality, and that's another syndrome called Romano-Ward. Some families have been reported that relatives with Brugada syndrome and LQT3 suggests basically that these conditions may be different types of the same disorder. Despite the identification of the 18 genes that we saw previously, 65 to 70% of clinically diagnosed cases remain without an identifiable genetic cause, and that just remains unknown in this field. Patients with Brugada syndrome can present with dizziness, fainting, severe breathlessness, fast and chaotic heartbeat, sudden cardiac arrest, and if not treated immediately, the sudden loss of heart function can lead to sudden death.
Hi guys, so I'm going to be telling you about the different methods of diagnosis for Brugada syndrome. Okay, so Amira just mentioned some of the symptoms that may occur with the syndrome. So basically what happens is if you have these symptoms, your healthcare provider will investigate the electrical activity in your heart with an ECG if they cannot be explained by like a more common condition. But having a Brugada ECG pattern may not necessarily mean that you have Brugada syndrome. So the next step would be to do a drug challenge if the diagnosis is unclear, or if you have the ECG but no symptoms, just to make sure. Next slide, please. So what the drug challenge is you're given a medicine that blocks sodium channels, and then several ECGs are done over a period of time when the drug is administered to detect changes in your ECG, and it just continues until they find something, so they diagnose you, or they find abnormalities, or the maximum dose is reached. And for post-test monitoring, it depends on the half-life of the drug as well. So usually what they do is they'll just keep checking out your ECG until it has returned to baseline conditions. Next slide, please. Okay, so this is just on the left. I have two diagrams just to remind you guys of an ECG, what it looks like normally, and the associated pattern and electrical activity that it represents. On the right, I have a graph to show you what happens when the drug challenge test is done. That's a drug called adrenaline, I think. Yeah. And basically what we're looking for here is in the V1 section and the V3, which here is written as V1 IC3. There's just different notations. You have an ST elevation in those two leads. And what a lead is, a precordial lead is basically just, if you like, coordinates to show you, to locate different parts of your heart in a horizontal plane, if that makes sense. So you have an ST elevation in those two parts if you have the Brugada syndrome, and that's how they diagnose you. So this test is done in the patient and in family as well, just to check for family history and stuff like that. Next slide, please. So there's also diagnosis by CMR. CMR, cardiac magnetic resonance imaging, is a radiology technique that is used to check for abnormalities, basically. Yeah, that's what it is. And for patients with Brugada syndrome, they tend to have larger ventricular volumes, obviously, because they might have arrhythmias, they might have plaques, or just abnormalities in the wall in general. So that's what we're looking for in a patient with Brugada syndrome. So this is just another measure taken to make sure that they have the disease, because it's hard to detect and could be obviously potentially very dangerous.
Okay, so moving on to the treatments. So the treatment differs depending on how high the risk of developing a serious abnormal heartbeat is, with higher risk needing specific treatment. So one is considered high risk if they have a personal history of serious heart rhythm problems, fainting spells, or have previously survived a sudden cardiac arrest. So if one does not have any of these symptoms, there is no specific treatment that is needed, as their risk of developing a serious abnormal heartbeat is likely to be low. However, a series of steps will be suggested by the doctor to lower the chances of an abnormal heart rhythm. So this includes 3 of the following listed there. At the first sign of a fever, doctors will treat the fever aggressively, as fevers are known to trigger abnormal heartbeat in people with Brugada syndrome. Secondly, certain drugs such as heart medications and antidepressants increase the risk of developing an irregular heartbeat, and therefore doctors will advise patients with Brugada syndrome to avoid certain drugs and instead undergo other alternative forms of treatment. So for example, an alternative for antidepressant in a patient with Brugada syndrome would be transcranial magnetic stimulation. And finally, excessive drinking of alcohol will also contribute to the increase in risk of the development of an abnormal heart rhythm. And similarly, competitive sports also have the same effect, and therefore patients are advised against both of these activities. Now, if a patient has had cardiac arrest or a fainting episode, the first or the main or first line of treatment would be an implantable cardioverter defibrillator, otherwise known as an ICD. And this is a small and battery operated device that is placed into the patient's chest, and it essentially continuously monitors the patient's heart rhythm. And when there is a need to control abnormal heartbeats, the device will deliver electrical shocks, and it is a device that is capable of performing cardioversion, defibrillation, and pacing of the heart. So drug therapy is when a drug is also given along with the ICD. A named example of this drug would be quinidine. Moving on to catheter ablation, this treatment is usually offered as an alternative in the event that the ICD given to the patient is unable to effectively and safely control the patient's symptoms of Brugada syndrome. So catheter ablation is when a catheter, which is a long and flexible tube, is inserted through a blood vessel in either the leg or the neck of the patient and is threaded to the heart. So the cells that are causing this abnormal heart rhythm are then destroyed to help return the heartbeat to normal. There are two ways in which these cells can be destroyed. So in radiofrequency ablation, the doctor uses the catheter to send radiofrequency energy and make circular scars around each vein or group of veins. Whereas in cryoablation, a single catheter is used to send a balloon topped with a substance or material that will freeze the tissue into scars. Moving on to the complication of these treatments. For ICD, it was found that unnecessary shocks were being provided, i.e. even when there is no abnormality in the heart rhythm. And the main problem with ICD is actually that it involves the implantation of transvenous leads, which has its own set of risks, such as infections. And these leads that are implanted will also be encased in scar tissue, and therefore it will be very difficult to remove when the replacement is needed, which is every 4 to 6 years, depending on how often the shocks are being delivered. And this actually led to the development of subcutaneous ICDs, which I believe is called the extravascular ICD system, or EV-ICD system, which instead places the leads under the sternum and leaves the venous system untouched while still providing the same benefits that the traditional ICD does. Moving over to the complications of cardiac ablation, I would say that these are more towards the possible side effects of such a procedure. So the list includes bleeding or infections where the catheter was inserted, damage of blood vessels if scraped by the catheter during insertion or extraction, and so on. Moving on to ethical concerns, Mabel actually isn't joining us today because unfortunately she does not feel very well. So yeah, you guys already know this. So I think Amira will be taking over this.
Yeah, so we probably, everyone here knows the 4 pillars of ethics in medicine, and we'll just be applying that to whether we think treatment of the Brugada syndrome is ethical or not. So first we have genetic testing / artificial intelligence. So confidentiality is keeping data and information about a patient private. So genetic testing might be a violation of confidentiality. If the AI system has been breached, patient data can be published and revealed. And here's like a little quotation that I think backs up the point. The world of medical AI requires patients to give up a lot of privacy and increases the chance that they might be more easily re-identifiable, with the attendant stigma and material consequences. Also, we have justice. So this form of treatment is very costly. So that raises the question of would it be accessible to everyone? Depending on the nature of genetic testing, costs can range from under £100 to over £2,000. Some patients simply cannot afford this. And we have patient autonomy. So it can be argued that consent is not informed because it's not certain how medical technology like AI reached their diagnosis. However, it can be argued that this principle can also be applied for other treatments like MRI, drugs. You don't expect the full-length explanation, but it has been shown to be reliable. So that can kind of come to argue the principle that genetic testing may undermine patient autonomy. Sorry.
So obviously the information from any kind of genetic test can affect the entire family, because obviously it's usually passed on, so it's usually a genetic problem anyways. So in terms of utilitarianism, it's good for society because it allows the family to find out earlier. It's better for prevention, and obviously if more people have it in the family, will find out and be able to help them as well. But in terms of libertarianism, it raises an issue for autonomy and confidentiality, because we see this a lot in medical ethics. Sometimes a patient might not want to know when they have risk for something as life-changing potentially and dangerous as this. So that raises issues for autonomy, and yeah, there's two sides to it.
Right. So for treatment, so the treatment for Brugada syndrome, so ICD, is actually really, really expensive, and you can see from the two little quotes at the bottom. So in the UK, the cost is estimated at around £9,692, and in the US it's around 30,000 to 50,000. So this is really, really costly, and so people who need it might not actually be able to afford it, and so therefore equal access is not guaranteed for everyone, and treatment is therefore refused to people who can't afford it. And this goes against justice and non-maleficence. So these are the notable cases that I mentioned at the start, and you guys can go back and read this because it is very long. Yeah. Moving on to the innovations and analytics. Frida.
Hello?
Yeah.
Can you hear me? Okay, sorry. So we thought of a few things. It was actually kind of difficult thinking of improving treatment, because most of the problems we found are basically already solved for. But one thing we thought of was education, because I think the biggest problem with the syndrome is people not really knowing about it. And obviously because the symptoms could be for something more common, people may tend to ignore them, chest pain and so on. So it's very important that awareness be raised, so people know that Brugada syndrome is hard to detect and they could have it, and everyone out there knows that faster detection is better. The next point is further treatment. We thought about genetic engineering, which we could use to remove the genes that cause Brugada syndrome. Obviously, that's still being developed. And the last point is to do with diagnosis. We were thinking with AI constantly improving in medicine, the use of AI increasing, it could mean we could get earlier diagnosis of Brugada syndrome, which means earlier prevention and treatment.
All right, so these are our references, and that is all. Thank you.
Thank you to the speakers for your presentation, and we're now going to hand over to Samath for his comments.
Hi guys, sorry for being a bit late. So first of all, you really went to town with this presentation. It was to the detail and I really liked it. A couple of things that I want to point out is that in clinical practice, when you are going to be the doctor, what you're going to do is a patient is going to come to you and he's going to have some complaints, isn't it? So it's not that a doctor directly goes to the diagnosis of Brugada syndrome or say any other disease like that. So there are some complications with the Brugada syndrome that you just pointed out. It can cause, most of all, death by syncope and cardiac arrest, isn't it? So in that case, a complication like that, how do you think that you quickly go to the diagnosis of Brugada syndrome and start the treatment with channel blockers and all that? So it's a tough ethical scenario, and even like great doctors, they sometimes fail with it. So one of the questions that I had about this was, no one of you mentioned about the criteria for diagnosis, because there's a specific guidelines for every disease, scoring criteria that helps you determine if you need to start treating for the particular disease. So this is, does anyone come across this scoring system for Brugada syndrome during your research? Oh. Anyone? Am I audible? All right. So anyway, it's not a big deal, but remember this, that we as a doctors, or we as a first year interns, foundation year doctors, or anything, we don't know much. Even our seniors, resident doctors, they don't know much about everything. So there are these guidelines from various associations, like the American Heart Association has these guidelines on CPR. So these guidelines are there to help you to come to a diagnosis about these rare conditions. So there's a Shanghai score system which relies on four things: the ECG results, the clinical history of the patient, the family history of the patient, and the last thing that you very beautifully pointed out, the genetic testing for the gene, if the gene is mutated or not. So there are the scoring systems. If you get a particular score, you have a probable case of Brugada syndrome. If you don't, then there is less chance. So these help you to shape your diagnosis. One last thing is that a lot of some of you talked about the LQT3 the disease that is related to the QT interval. The thing with that is that a lot of doctors start focusing on that, which may be coexisting with the Brugada syndrome, and the treatment of that syndrome requires channel blockers. So an ethical choice or smart doctor decision would be to not use channel blockers, because you already know that in Brugada syndrome there is a disorder of pathology of the channels, isn't it? So keep that in mind as a doctor. It's very rare you will come across the Brugada syndrome in your clinical practice, but still, so these small things you should keep in your mind. Other than that, I really liked your presentation. It was to the point, interesting. It made me refresh my knowledge about Brugada syndrome. Thank you so much. Well done.
Thank you for your feedback. Now we're going to have the next group who will be presenting about septal defects. Good luck.
Is McQueen here to present?
Yes, I'm sorry. I'm
Oh.
trying to. I have some problems with the security.
Oh, okay. No
Apparently,
worries.
anything. Huh? Cannot share your screen. System. Oh my god. Angel will share the screen.
It says here that everyone can share their screen, which is strange. Oh, there we go.
So good afternoon, everyone. The topic that we would cover in our lecture today is septal defects, which we would have questions scattered throughout our presentation for consolidating all of our comprehension of today's topic. May I have the next slide, please? So septal defect is a congenital heart defect in which there is a hole in the septum that divides the chambers of the heart, which usually occurs during pregnancy if the septum of the fetus does not fully develop. There are two types of septal defects, including atrial septal defects, as known as ASD, which occurs between the atria, and ventricular septal defects, which happens between the ventricles. Here, the following list includes all 9 types of septal defects, which would be further discussed later.
So both types of septal defects begin with the formation of the heart, which happens in the fetus. It is composed of a chamber. The formation of the heart, or heart morphogenesis, is composed of chamber formation and cardiac septation. Today, we'll be only focusing on the cardiac septation since it's more specific to the causation behind septal defects. So, in a fetus, a natural connection between the left and right atria is formed. In the fourth week of gestation, septum primum grows from the roof of the common atrium, and a gap called the ostium primum is formed. So as you can see in the first image, the line that begins to grow from the roof of the heart is called the septum primum, and then it doesn't completely connect with the endocardium cushion. So it leaves a little hole called the ostium primum. Now, whenever I refer to septum, it's like referring to the sheet that grows out of the heart, and whenever I refer to something as like ostium, it's like a hole, basically. So next, the gap. But however, after a period of time, the gap disappears, and the septum primum begins to merge with the endocardial cushions. Later on, another gap called the ostium secundum is formed. It is between the primitive left and right atria, right of the septum primum. The septum primum is formed from the roof. The septum secundum is formed from the roof. As it grows, it covers the ostium secundum gap. However, it does not completely separate the two atriums. It leaves another gap called the foramen ovale. Now, if that was confusing, try picturing this. So a line called the septum primum, so the initial line, grows from the roof. It grows downward, but stops for a period of time, leaving a gap called the ostium primum. So the septum primum corresponds to the gap called the ostium primum. And then, but then after a period of time, the line begins to grow and the gap is closed. And then afterwards, another line begins to appear called the ostium secundum, and then it begins to grow as well, but then it does not fuse completely, and but then it covers, and another line called the ostium secundum begins to grow, covering the whole. The two line begins to fuse and form the atrial septum. So why does this whole convoluted thing happen? It is because in the developing newborns, they get oxygenated blood from the placenta, which goes from the umbilical vein over to the right atrium, which is different because after development, only the oxygenated blood goes to the right atrium, which is then sent to the lungs to pick up some oxygen in the developing fetus, though it's already oxygenated. So instead of going to the right ventricle into the lungs and back to the left atrium, it just bypasses the right ventricle and the lungs through the foramen ovale and into the atrium, into the left atrium, where the oxygenated blood gets pumped throughout the body. So why does this happen? Well, in short, the two lines in short, the two lines don't fuse completely. They don't fuse correctly. But then we will learn later there will be many different kinds of ASD. So here comes a question. Hello, next slide. Yeah. So when the septum primum, so which this is the initial line that grows from the roof of the cardiac, from the heart, fails to connect with the endocardium cushion, what type of ASD is formed? So a hint to this question is to look at the bottom part of the septum primum. And to answer this, you need to know like which hole corresponds to the septum primum. It's all right if you don't know.
Is it septum secundum?
The septum is referring to the line, remember? And the other word is used to refer to the gap.
Ostium secundum.
Yeah, it would be the ostium secundum defect. Well done.
There are in total 5 types of atrioseptal defects, including patent foramen ovale, ostium secundum defect, ostium primum defect, sinus venosus defect, and coronary sinus defect. But why will the gap appear at the atrial septum, causing ASD? Researchers found that the left atrium is the main factor that contributes. The HH signaling, which is a pathway that transmits information to embryonic cells, is secreted from the pulmonary endoderm and is required for the atrial septum formation. Besides, the haploinsufficiency of TBX5 gene will result in ASD and is associated with Holt-Arm syndrome. Next slide, please. We'll briefly go through some types of ASD now. The first one is septum secundum. It is describing the situation of a fold of the dorsal atrial myocardium, and it usually arises from enlarged foramen ovale, inadequate growth of the septum secundum, or the excessive absorption of septum primum. Around 10 to 20% of the patients with ostium secundum ASD will also have mitral valve prolapse. And we come to the most common type of ASD, the ostium secundum. This is caused by incomplete adhesion between the flap valve with the foramen ovale and the septum secundum. Some statistics points out that secundum ASD is the most common type of septal defect. A study based on 128 consecutive patients with atrial septal defect over the age of 18 years or above is done, and the results show that the secundum defect presents in nearly 85% of all ASD cases. Another one shows that 65 to 70% of the patients with secundum defects are female, which means that female are more vulnerable to it. Ostium primum is another type of atrioseptal defect. It is a failure of growth of the vestibular spine to complete atrioseptation. Around 10% of the cases are ostium primum defects, and the male to female ratio is nearly 1:1. It is proved that it correlates with trisomy 21. Therefore, a quarter of Down syndrome cases are associated with ostium primum defect.
The patent foramen ovale is a minor defect where the foramen ovale is not closed when the baby is born, but the hole is still covered by the tissue flap. As normally a thin membranous wall made up of 2 connecting flaps separates these chambers, so no blood can flow between them. But if a PFO exists, a small amount of blood could be able to flow between the atria through the flaps. Followed by sinus venosus, which is a rather rare congenital heart disease that can occur near the superior or inferior vena cava. permits shutting of blood from the systemic to the pulmonary circulation caused by a deficiency of the common wall between the superior vena cava and the right-sided pulmonary veins. And finally, coronary sinus defect, which is also a rare congenital heart disease, comprises less than 1% of all ASD cases. And here is the second question. What is the name of the ASD which has the highest occurrence?
I'm not sure, but is it the secundum defect?
Yeah, it is. It's the secundum defect.
After describing how atrial septation is undergone in some ASD types, then we are coming to ventricles. The ventricular septation is relatively simpler than the atrial septation. From the end of the 4th week, muscular septum grows from the floor to the ventricles. It then partially divides its area into left and right ventricles. In this stage, the interventricular foramen between the muscular septum and the fused endocardial cushions remains open. The inferior endocardial cushions then develop on the top of the muscular septum and fuse with the conus septum. And finally, the hole there is closed by the membranous part of the interventricular septum. This is how it should work. However, in some cases, the hole is not completely closed. This leads to the ventricular septal defect. There are 4 main kinds of VSDs, including membranous defect, muscular defect, atrioventricular canal type defect, and conal septal defect. Both the left and the right ventricles are responsible for the ventricular septum formation. Once again, the VSDs are caused by the mutation or deletion of the gene TBX5, which is located on the long arm of chromosome 12. The gene is involved for limb and heart development. Therefore, the malfunction of gene will lead to limb abnormalities, which is hold arm syndrome mentioned before, and cardiac malformations. We'll look into 2 common types of VSD this time. The first one is the membranous defect. This is the type of VSD that is most commonly operated on, as the gap does not usually close spontaneously. There is an opening at the upper section of the ventricular septum near the valves, and the second one is the most common type of VSD, the muscular defect. While in large number of cases, the hole will be closed spontaneously and do not require surgery. It's an opening in the muscular portion of the lower section of the lower ventricular septum. Here comes the third question. What is the name of the gene that causes VSD if it is mutated or deleted? Does anyone know the answer? Okay, maybe I'll just show the answer out. It is the TBX5 gene.
So now before we talk about the blood flow of ASD and VSD, I think, and its repercussions, I think it's useful for everyone to, if we quickly recite the blood flow of a normal heart. Okay, so with the normal blood flow of the heart, everything starts in the right side of the heart. And the goal of the right side is to get oxygenated blood to the lungs. So blood enters it through the superior and inferior vena cava. It flows down into the right atrium, where it goes through the tricuspid valve, where it opens up and allows blood to flow into the right ventricle. So the right ventricle will contract, it will shoot blood up through the pulmonic valve, through the pulmonary artery, where it's gonna get right to the lungs, and the oxygenated blood becomes oxygenated. Now the blood returns back to the heart via the pulmonary vein, where it's going to go through the left atrium, through the Buschke valve, and into the left ventricle. And the left ventricle is very strong because it has to be strong enough in order to pump all the blood throughout the body. So it has to generate a lot of pressure. Now that blood is pumped through the aortic valve and through the aorta and all throughout our body. Now, how does a ABS blood flow differ from that? So, ABS, we're talking about a connection between the left and right atrium. So there's a hole in the septal. Regardless of which type of ADS, the mixing of blood will occur, and this will lead to a whole host of medical complications. The first thing that will occur in a atrioseptal defect is that the blood from the left atrium leaks into the right side. Now, why does this occur? As I mentioned before, it is because the left side needs to pump blood through the entire body and needs to create enough pressure and the right side only needs to create enough pressure to deliver the blood to the lungs. When this happens, the blood that has already been in the right atrium is returned back into the right atrium, causing the right ventricle and atrium to enlarge to adapt to the increased blood capacity. Please note that this is a very important detail that we'll come back to later when we talk about pulmonary hypertension. Now, over time, the shunting of blood from left to right will reverse into right to left. And this is what is known as Eisenmenger syndrome. This is a irreversible medical condition and potentially very deadly. So the oxygenated blood will travel from the left atrium, which will continue the journey from the right atrium to the left atrium, and it will go and continue its journey into the left ventricle, and this will cause the deoxygenated blood to be pumped around the body. Okay.
And I'll briefly explain how the blood flow in VSD patients. Initially, the pressure of the left side of the heart is greater than the right side of the heart. Therefore, a VSD allows oxygenated blood to mix with deoxygenated blood. Some oxygenated blood that should have been pumped to the rest of the body is pumped to the right side of the heart. This will include increase of blood pressure and the blood volume in the right ventricles and pulmonary arteries. The pulmonary blood flow increases. This results in overload and enlargement of the left side of the heart. And over time, it may lead to congestive heart failure or arrhythmias. And here comes the fourth question. Can anyone tell which side of the heart will have a higher pressure initially in ASD? Okay, so the answer is the left side. I'm sorry about it, but yes, the answer is the left side. Thank you.
Okay, so before we go on to the diagnosis of septal defects, I'd like to just quickly touch on the pathophysiology of septal defects. So pathophysiology is essentially a term used to describe how a disease comes about and which biochemical systems it involves. In septal defects, the defect usually happens during pregnancy if the wall that forms between the two ventricles doesn't fully develop, leaving a hole. There are two types of septal defects, the first one being an atrial septal defect, which is essentially a hole in the wall between the heart's two upper chambers, the atria. ASD is a congenital condition, which means it is present at birth. Next, a ventricular septal defect is a hole in the wall between the two lower chambers, the ventricles. In children, a VSD is usually congenital as well. So how do we diagnose congenital septal defects? In babies, these septal defects can be diagnosed even before the baby has been born. Doctors can detect them on antenatal scans and also by listening to the baby's heartbeat with a stethoscope, which will reveal a murmur. This usually happens at newborn baby checks, as well as a 6-week check performed by the GP. However, these defects aren't always detectable at birth or antenatally, especially if the defect is very small. So instead, they may be detected even at adulthood when patients may be present with chest pain or breathlessness, but this breathlessness isn't related to exercise. As a result, your doctor will take a complete medical history and perform several types of tests, which may include the following. A transesophageal echo diagram, which is a picture taken by numbing the throat and then sliding a thin tube containing an ultrasound device down the throat and into the esophagus close to the heart. Next, another way is using an echo diagram, which an agitated saline bubble test is an ultrasound taken at the heart while saline bubbles are injected into the bloodstream. An echo, or a heart echo, is an ultrasound that shows how blood flows through the heart. It can help a cardiologist diagnose the location and size of the defect. A fetal echo can even diagnose a septal defect before birth.
Your doctor may also perform an MRI test to check and see whether the defect is present in the heart. So an MRI involves the use of radio and magnetic waves to take detailed images of the heart. So you can see from these two MRI images, the defects are clearly visible right here, in the gap right here and here. If doctors want to rule out even a very tiny hole, they can do a test called the bubble study. So a cardiologist will inject sterile water containing many micro bubbles into a vein in the arm. So the water makes its way to the heart. On an ultrasound, bubbles in the water will show up as white. The doctors can now see how the bubbles flow through the heart with the blood. So a bubble study is typically done on older children or adults and may require sedation. Normally, our lungs will simply filter out the bubbles, but if we have a tiny opening between our heart's upper chambers, which is the right and left atria, some bubbles will move through this hole and appear on the left side of the heart. This opening is called the patent foramen ovale, and 1 in 4 people have this finding. The hole is usually present in everyone before birth as a normal part of development. However, when it fails to close fully after birth for a period of time, the PFO is considered as a defect. So here is an ultrasound image from the bubble study. As labeled here, there are some white dots, which are the bubbles present in the left atrium of the heart. So this means that there has to be an opening between the chambers, allowing the bubbles to move across the hole from the right atrium to the left. So now to our next question. Here in front of us is an MRI image. So can someone help us identify what type of defect is present here? So a small hint, you can try to find where the gaps are in the septum. Is it the Is it ASD? Yes, you're correct. So as you can see here, there is
Are you okay?
So there's a tiny septal VSD. I'm sorry. So the internet kind of logged off, but then there's a tiny septal VSD right here, which many people might have missed because it's really very small and not that clear. But there is also, as you pointed out, there's a moderate size ASD right here. So that's more obvious, and I'm very glad that you can point that out. So moving on to treatments. So how do we determine the type of treatment suitable for each patient? So when we are determining this, we mainly look at the size of the defect and the time needed for the defect to close, which is how long has the defect been present. So The size of a defect is classified into 3 categories, and they will be treated in different ways. As we can see here, there are small, moderate, and large defects. Also, if the defect hasn't closed on its own during the first 2 years of the child's life, surgery may be needed to prevent any serious complications.
So the wait and watch approach is used when there is only a small defect in the septum and when it is not causing any serious symptoms. In this approach, the doctor will wait and monitor the patient's condition and see if the defect corrects itself. Some small septal defects can also close on their own as the child grows, especially when the defect is located in a part of the septum that is all muscles. For the medication approach, it is usually used when the patient needs surgery. The goal of medication is to decrease the amount of fluid in circulation and in the lungs, also to control the symptoms before the surgery. The medication used may include digoxin, which is a type of medicine called cardiac glycoside. It's used to control some heart problems, such as arrhythmias, including atrial fibrillation. It can also help to manage the symptoms of heart failures, usually with other medications. Another drug like digitalis can also be used. It is a drug that is used to treat congestive heart failure and heart rhythm problems. And diuretics is also a drug that can be used. It helps the kidney to get rid of unneeded water and salt and make it easier for the heart to pump. It can also ease the swelling and water buildup caused by other medication problems, including heart failure. These medications will help the patient to get into the suitable condition to receive surgery. So an atrial septal defect transcatheter repair procedure is a minimally invasive surgery, and it involves inserting a thin tube or a catheter into a blood vessel in the groin, which is a place between the abdomen and the thigh, and then guiding it all the way up to the heart for closure of the defect. This procedure is usually recommended for an atrial septal defect. During this procedure, a pediatric interventional cardiologist makes an incision in the groin, inserts a catheter, and funnels a small mesh patch through the catheter and up to the hole in the heart. Over time, the child's own heart tissue will grow over the patch. And for that, in another procedure, which is called the open heart surgery, the patient will be anesthetized and put on a heart-lung machine. The surgeon will make an incision in the patient's chest and close the septal defect with either stitches or a patch. A ventricular septal defect is usually repaired with open heart surgery, though some children may be candidates for a less invasive procedure, which is like the transcatheter repair procedure. And during an open ventricular septal defect surgery, the surgeon accesses the heart by opening the sternum, and the patch is applied to the septal defect. Open heart surgery is also necessary for ASD that cannot be repaired with a transcatheter device. So now there's a question about how do we determine which type of surgery is suitable for the patient? If anyone would like to answer it.
Look at the size of the defect and the time needed for the defect to close.
Yes, you're correct. So I'll move on to talking about the complications of septal defects. Next slide, please. So for the complications for the small defects, when defect size is classified as small, they will just cause limited complications or never cause any problems, as they often close during infancy. And for the complications for larger defects, when the defect size is classified as large, they will cause more serious problems. For example, it will cause pulmonary hypertension, congestive heart failure, arrhythmias, lung infection, increased risk of stroke, stenosis, and infective endocarditis. The increased risk of stroke is caused by a blood clot forming and passing through the defect in the septum and travel to the brain. Originally, the clot may be lodged in the lungs and cause less serious consequences. And in pulmonary hypertension is caused by increased blood flow into the lungs, and this will increase the blood pressure in the lung artery as an attempt to decrease the amount of blood entering the lungs. The lungs artery begins to narrow, leading to pulmonary hypertension. And the reduced blood flow makes it harder for the right side of the heart to pump blood through the arteries. If the right side of your heart has to continually work harder, and it can become weaker, and it leads to heart failure. And there are also some more rare and more serious complications. For example, it will cause pulmonary heart disease and Eisenmenger syndrome. Pulmonary heart disease is caused by extra blood flowing through a large septal defect. This may overwork the right side of the heart. If it is not treated, the right side of the heart eventually enlarges and weakens, leading to pulmonary heart disease. As for the Eisenmenger syndrome, is caused by a ventricular septal defect. It causes an abnormal circulation of blood. The defect allows blood that has already picked up oxygen from the lungs to flow back into the lungs instead of going to the rest of the body. When some of the blood in the right atrium flows to the left ventricle due to the defect, the amount of blood flowing to the lungs increases, and the heart will need to work harder to pump blood into the lungs, increasing the pressure in the lungs, and this may cause permanent lung damage. So we'll have another two questions. The first one is, what is the reason of small defects not causing any problems? Can anyone maybe answer that? So maybe I'll just.
Do the defects, like, because in an infant they usually close on its own?
Yes, you're correct. And as for the next question, why does having septal defect increase the risk of having a stroke? So maybe I'll just tell you the answer, which is if there is a blood clot, it will flow. Originally, it may lodge in the lungs, but then when there is a defect, it increases the risk of the blood clot flowing into the brain.
So here are some innovative ideas to further treatment. So the first, one of the innovative ways we could possibly use, which could be possibly used to treat septal defects in the future, would be nanotechnology. Due to the unique size, physical properties, and chemical composition, many of nanotechnology and nanoparticles are already used in targeted delivery of drugs, etc. So it has been proposed that nanotechnology can be used to deliver mesh material to the area of defect, where they can self-expand and then fill the septal defect. Okay, so for our last part is the medical ethics. So here are the 4 pillars of medical ethics, as already discussed before. So one of the major medical ethics associated with septal defects is whether a child should have open heart surgery or not, because the risk of open heart surgeries performed on children is very high. There could be excess bleeding, infection, blood clot, which could lead to other problems, abnormal heart rhythm, and heart block. And many people debate on whether, because the child doesn't have a consent over whether open heart surgery is performed on her, so the right is left to the parents. So there are many debate over these and other, as well as other diseases that are present in very young infants. So this is the end of our presentation. I hope you have learned a lot about septal defects, and yeah, thank you.
Thank you, guys. So it was a very informative presentation, quite long to be honest, but I enjoyed it, and definitely it's taught me a lot more. So does Samarth want to give his comments?
Yeah, I have a question, a rather simple one. So imagine you are in a, like, I don't know what you want to do after your specialization, but imagine you are a neonatologist or a pediatric doctor, and a baby comes to you completely normal. And in a regular checkup, you notice that the baby has cyanosis, blue skin, of that sort. So just as a precautionary measure, you order a ECG, because there must be a problem with the heart if there is a central cyanosis. So in the ECG, you find some ECG disturbance, and as a result, you get to check X-ray of the heart, and in X-ray of the heart, you find out that septal defect that you talked about. So what do you think your next go-to should be as a doctor or as a consultant, whatever? Anyone?
So if blue skin is appearing on the baby's appendages, it's a clear sign that blood is traveling from the right side to the left side, which is causing the deoxygenated blood to be pumped throughout the body. So in order to compensate that, I think there will be a surgery will definitely be an option. But then temporarily, since due to the risk, it will not be done spontaneously. It will not be decided spontaneously. I think it will be first treated with medicine. It can control the heart rhythm, to control the beats per second of the heart. Just try and manage the symptoms with medications, and then decide later, do an analysis of whether heart surgery is worth risking. Meanwhile.
Okay, so your first like answer was to go for the heart surgery. So usually first instincts are bad, but in this case your first instinct was good. But septal defect, small or big, for a baby showing signs of cyanosis, is direct indication for a heart surgery, because you need to close that heart defect. Because if you treat it with, like you said, disease, medication that can increase the heart rate, it can cause further complication. The heart defect can open up, which will create more blood going into the left to right. So talking about left to right, I saw that you talked about the left to right shunt. I would have liked you talking more about the pulmonary complications of the right to left shunt as well, because you know that in case of formation of right to left shunt, the blood goes into the pulmonary circulation a lot, and left to right shunt, the blood goes into the pulmonary circulation a lot, which causes pulmonary edema. So the lungs get filled with fluid. So generally what happens is that because of this disease, which you see in an X-ray as fluid getting accumulated in the lung, it can be misdiagnosed for pneumonia or say pleurisy. So they go for treating antibiotics and say pleurocentesis or whatever, but in the reality, the defect lies in the heart. So your first instinct was good. If you find the heart defect, consult a pediatric surgeon and then go for the surgery, because it can get complicated. So yeah, other than that, you talked a lot about like the fine details, the genetic etiology and all that, and it was really good. I think overall it was a really nice presentation. Thank you so much. Well done.
Thank you.
Yeah, thank you for this presentation. And that will be the end of our session today. Before we say bye to Samarth, do you have any last words or final?
Oh yeah, thank you for inviting me. It's good to see all of you. I think you are in year 12 or year 11. preparing for your med school. So having this much information even at this age is a lot. I know a couple of my friends who don't even know what heart defects are. So it's good that you are preparing at this time, not preparing, just having a gist of it in your mind. So yeah, it's good to see you all getting interested. And thank you for inviting me.
No, thank you for coming. So before we all leave, I'd like to say thank you for everyone for coming to Mediccom Event 5. And it will probably be a little bit of time before our next session, simply because of we've got BMAT in the way and interviews to prepare for. But hopefully we'll try to get something done next month, because obviously school is coming back and everyone is getting more and more busy. So regardless, I hope everyone has learned something about heart diseases, has something to take away, something about ethics, maybe something that they can talk about in the future, whether that is in their personal statements or in the interview, because that's what Mediccom is here for. Mediccom is here for you guys to try get as much as you can out of education and academics and personal research as possible that you can speak in the future. So regardless, I hope everyone is good. And finally, I'd like to say, please donate to our charity link. It's in the Google Meet chat, and that is for the British Heart Foundation, who are responsible for a lot of innovative research done for heart diseases, as we've highlighted before. And finally, please subscribe, follow us on all our social medias, LinkedIn, Instagram, and I hope everyone has a good rest of the day. Thank you.
Thank you.